Hello, welcome. Yep. Hi, we're going to get started. Thank you. Hope everyone's enjoying their lunch, great food. And now we're going to have some serious talk. Hello, everyone, and welcome to the event, whether you're joining us here in person at the Globe and Mail or virtually across Canada. My name is Andre Picard. I'm the health columnist at the Globe and Mail, and I'll be the moderator for the event today. To begin, I want to acknowledge that we're on the ancestral and unceded territory of the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples. Toronto has long been and continues to be home and a meeting place for many First Nations, Inuit, and Métis peoples. Elder Wabigoon, who you'll hear from in a moment when she opens the conference, always encourages us to go beyond the standard statement and make a personal reflection as part of the land acknowledgement. So I want to add this today in the spirit of our event. Today we'll be talking about health and climate change. No one has been more impacted by the degradation of our ecosystem and climate emergencies like wildfires than Indigenous peoples. An essential part of the process of truth and reconciliation must be to give voice to an Indigenous perspective when it comes to the environment. Call to action number 92 calls on government, corporations, and by extension all of us to, quote, commit to meaningful consultation, build respectful relationships, and obtaining the free, prior, and informed consent of Indigenous peoples before proceeding with economic development projects. In other words, to give life to the notion of stewardship. Hopefully that will be an integral part of our conversation today. So I'd now like to introduce briefly Elder Wabigoon. She's an Ojibwe elder who sits with the Loon clan, a keeper of the sacred pipes, a member of the Obi-Shikuwaganog Lake Sewell First Nation, and a 60s scoop survivor. She's a writer, speaker, land defender, and water protector. She's also co-founder of the award-winning youth program, Nikibidao, Dawadina Jiguan. I practiced. Hopefully I'm as good as last time. She's been coaching me. And part of this is treating youth to shape them to be the caretakers of Mother Earth in the future. So I'd like to invite Elder Wabigoon to the stage to join us. Elder, I'd like to respectfully request that you open and close our conference today. Give us that honor.
Yes,
Thank you.
Thank you, Chimikwich.
Thank you.
Bonjour, in Dinaway Maganadok. Anin. The Comus Wabigoon Indigenous Kazo, Bishop Okang, Lake Sewell First Nation, meanwhile Toronto and Dunjaba, Mangdoran. What I said was an Ojibwe protocol greeting, and I said, hello, all my relations. I see your light. My name is Elder Wabigoon, flower blooming in spring. I'm from the Narrows abundant with white pine. I'm a member of Lake Sewell First Nation. I've resided in Toronto for 48 years. I sit with the Loon clan and I look after everything under the water. I'm a water protector and a land defender. I'm a survivor of colonial violence, the 60s scoop, and a witness to the resilience of these lands and the First Peoples. I greet you here in spirit of truth, healing, and responsibility. I want to say Chimikwich to the Globe and Mail and their event planning team and to the Canadian Medical Association for inviting me to open and close this health climate change event. Chimikwich to Andre Picard for acknowledging the land on which we gather today and for offering me this awesome tobacco and to open and close the space. I say Chimikwich to my helper Robin Rice for assisting me today, advocate and the 2025 delegate for Miss Universe Canada. So just a round of applause for her. So before I do the opening, I just have a few words that I want to say. It would be amiss of me not to. Water, our first medicine. She flows through our bodies and our histories. When she is poisoned, we are poisoned. When she is honored, we are healed. The land, our Earth Mother. She holds our bones, our stories, our medicines. She's not a resource. She's a relative. Her wounds are our own. The air is our breath. It's the quiet gift we receive before we even open our eyes. It moves through our lungs, our forests, our oceans. It's shared freely, endlessly between all living beings. But today, this breath carries more than life. It carries smoke from the burning forests. It carries disease born of imbalance. It carries despair from the lands that can no longer breathe. When the winds shift and the air grows heavy, we must ask ourselves, as human beings, as two-leggeds, what have we forgotten? And are we being good ancestors? Fire, our teacher of transformation. It can destroy, yes, but it also purifies, renews, and reminds us of our influence to change. You, healers of this nation, are gathered here to confront the climate change, but climate is not just a science. It's a spirit. It's a relationship. It's a memory. Our peoples have long warned of imbalance. We've seen the signs in the waters, the animals, the lands, the medicines. Now the earth, our mother, calls on all of us to listen, to act, and to heal. Let this gathering be more than spoken words. Let it be a promise to future generations. Whenever we gather to open a space such as beautiful as this, we want to open it in a good way. We want to open it with ease and balance, good words, good direction, and unity. What we say and hear today will ripple towards and forward, affecting the next 7 generations. Normally, I would smudge the space with sage smoke, but today I open with Mushkiki Nibe, sacred medicine water. I chose water so that everyone may have access to this sacred medicine today. I brought cedar gifted from the standing ones in the Halliburton area and sacred medicine stones from the Bulkley and the Skeena rivers where they meet at the Great Kazan in British Columbia. This is Mushkiki Nibe, medicine water. I share it with you now, and we honor the sacred water nearby, Lake Ontario. I ask you to recognize, remember, and be grateful for the water, not only today, but every day. Say Chi-miigwech the next time you take a drink of water, wash your hands, or maybe it's tonight when you take your shower. Speak to the water, respect the water, love the water. To open the space, we offer this medicine water with song. In gratitude to Mother Earth, the water, Nibe, and our beautiful standing ones with leaves of such glorious color, reminding us of harvest and change. I'm going to ask for the filming to stop here, please. As I sing, I ask you to give hope for those with too much water and prayer for those with not enough. If you know the song, the water song by Mash Kuntz and his grandmother Doreen Day, please join me. They have generously gifted us permission to sing the Nibe song wherever we are. And we say Chi-miigwech to them. The words to this song are, water, we love you, we thank you, and we respect you. At this time, I ask you to please stand. If you're unable, please remain seated and close your eyes. Nibe Gija Gehiko Chi-miigwech away Nimigo Gija way Nimigo Gi me kwechawe ni mi go. Gi shawe ni mi go. Ni ba gi sha ge hi go. Gi me kwechawe ni mi go. Gi shawe ni mi go. Ni ba gi sha ge hi go. Gi me kwechawe ni mi go. Gi shawe ni mi go. Please have a seat. So it's with these words, I urge you to remember the spiritual connection we all have with Mother Earth and all our relations, the swimmers, the flyers, the root nation, the plant nation, the standing ones, the tree nation, the air, the water, fire, all of our elements. They all came before us. They all came with their original direction and instruction. And they have followed it to a T. It is us that has gotten off the path of that sacred way. It's us that has to come back together to walk the sacred path, the red road of Minoba Matsuan. I want you to live the lesson that nature shows us. To live in harmony as one with all our relations. Look at the trees. Look at the fish. Look at all the animals that live in harmony. You don't see them going to war. You don't see them fighting. I asked the youth, what if the trees went to war? What would happen? But that's a silly question. So think about that. As we approach the next 7 generations, ask yourself, am I being a good ancestor? Thank you very much for listening, and we shall see you soon. Miigwech.
Miigwech, Elder Wabagoon, thank you for sharing your wisdom with us today, and we'll look forward to hearing you at the closing of the conference again. Today is the first National Day of Action on Planetary Health, a good day to discuss climate and health, especially when it's 25 degrees outside in October. Today we'll talk about 2 important themes: how climate change is affecting our health, and how the health sector can be part of the solution by reducing its greenhouse gas emissions. The links between our changing climate and health have become ever more apparent over the past several years, with wildfires raging across Canada, smoke advisories and evacuations, heat domes, bomb cyclones, flooding, and much more. Today we'll focus on these health impacts, but also on the all-important solutions. Before we get going, a couple of important housekeeping notes. The washrooms are located just outside on the left, my left, and just beyond the elevators. The Wi-Fi is Globe Events, and the password is on your table on that little plastic sheet, Globe and Mail #9. We'll have a bit of time for audience question as we go along. There'll be a mix of talks and panels. And for those of you in the virtual audience, please type your questions in the Q&A box. There's also a different button for tech support if you're having problems. And people in the room, please use the microphone so people online and in the room can hear you. Now, without further ado, let's get started. I want to formally recognize and thank the Canadian Medical Association for making today's event possible, and welcome to the stage Dr. Margot Burnell, President of the CMA.
So thank you very much, Elder and Mr. Picard. Good afternoon, everyone. Thank you for joining us, and to the Globe and Mail for bringing us together. Before I begin, I would like to acknowledge we are meeting today in Toronto, the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples. It is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. I make this acknowledgement to reflect our commitment to listening, learning, and walking the path toward reconciliation together. The CMA is proud to be co-sponsoring today's event alongside the Trottier Family Foundation as part of our work to take action on climate and health. We've heard the calls to action on the international stage with the World Health Organization describing climate change as the single greatest health threat facing humanity. We've seen the consequences in our own backyards with the rise in extreme weather events like heat waves, wildfires, and flooding, unprecedented in a few decades ago. Physicians and other care providers have seen the effects in our practices too, with more patients seeking care for concerns like asthma, heat exhaustion, and anxiety. More broadly, climate change is affecting how we live, work, and interact, impacting everything from food security to affordability. We also know that certain populations are disproportionately affected in northern, remote, and Indigenous communities. We can only anticipate that these pressures will worsen, and we need to be taking steps now to help us better prepare for what lies ahead. The healthcare system has an important part to play in promoting environmental sustainability. This is especially important when we consider that the system produces more greenhouse gas emissions than aviation and shipping. That makes us one of the worst healthcare polluters per capita in the world. Alongside physician and other partners, the CMA is currently advocating for environmentally sustainable health systems in Canada with a focus on reaching net zero by 2050. Today, we celebrate the first ever National Day of Action on Planetary Health, organized by the Canadian Association of Physicians for the Environment and supported by the CMA and other organizations from across the health sector. It's an urgent call for both more sustainable practices on the front lines of healthcare and a coordinated national response from the federal government. I encourage you to learn more about their calls to action on planetaryhealthday.ca. It's crucial that we act now to prepare Canada's health system for emergencies, and the federal government indeed has an important role to play. They must demonstrate leadership and provide funding for the development of an emergency preparedness plan. That includes conducting vulnerability assessments of healthcare infrastructure to identify local risks. As part of this work, they must engage in a meaningful way with Indigenous leaders who can provide insight on Indigenous knowledge systems and the standard of free, prior, and informed consent. They must also provide sustained resources for emergency response teams, including training local Indigenous health workers to strengthen community capacity and self-determination in crisis situations. In short, we need to act now so that our population and our planet remain healthy for generations to come. I'm heartened to be coming together with all of you to rethink healthcare in the context of climate change, prepare for what lies ahead, and chart a more sustainable path forward. With that, I'm very much looking forward to the afternoon's discussions. Thank you. Merci, miigwech.
Thank you, Dr. Burnell. And now I'd like to introduce our first presenter, who will help us provide some context and some background to today's topic. Please welcome to the stage Kim Parada, Executive Director of the Canadian Health Association for Sustainability and Equity. Kim is an environmental health specialist who's been promoting public policies that improve health, reduce health inequities, and protect the planet for more than 40 years. Kim, the stage is yours.
Thank you for that introduction. It's a real pleasure to be here today. I thought I was going to be talking to strangers today, and I've already seen quite a few people who I know. So now I actually feel shyer because I know that how much they know. Anyway, my job today is to give a brief overview of the health risks presented by climate change for people in Canada. But I'd also like to talk about or address the important role that health professionals can play in educating the public and promoting climate action. It's going to take me a little to get used to this. Okay, so before I talk about the experience in Canada, I just want to talk very, very briefly about climate change in a global context. I think that Canada is lucky with its geography relative to many other countries, and it's important that we keep that in mind. Using climate change attribution studies, several new studies researchers have done have estimated that climate change is actually responsible for 31,000 premature deaths from malaria, dengue fever, extreme weather, and from wildfire smoke alone. Now, this estimate excludes diarrheal disease and undernutrition, which has been predicted to increase premature deaths globally by 124,000 per year. So this is attributed to climate change. In fact, the 2024 Lancet Countdown on Health and Climate Change reported that climate change has substantially deepened food insecurity for 151 million people in 124 countries. So that was just last year. So just for all of us to take that in terms of just the impacts that it's already having on other people. Many of the countries that are hardest hit by climate change are the countries that are contributing the least to the problem. So there's the environmental justice issue of the century. Many of those countries are actually struggling to provide their people with food and water, and some, the island nations in particular, are actually struggling to exist. So before we get into the health risks for Canadians, I'd like to just note here that Canada is not the great climate performer that many Canadians believe it is. Canada has been one of the top 12 emitting countries for decades. And we've been very slow about reducing our emissions, even though we've made many commitments over the last 30 years to reduce our emissions. Between 2005 and 2022, Canada's emissions have increased by 1.3%. And at the same time, the US, who's not a great performer itself, has actually decreased its emissions by a little over 13%. And the European Union has decreased its emissions by 25%. Among the G7 countries, we are the laggard. We have not been doing our share. So just jumping into now, what's going on in Canada? So while we have not been hit as hard as other countries, we have not escaped the impacts. It's been increasing the frequency and intensity of extreme events such as hurricanes, ice storms, floods, and wildfires for decades now. It's been cutting people. These events can and do result in immediate injuries and deaths, but they also produce indirect health impacts. They cut people off from food supplies, medical care, and essential services by damaging infrastructure such as roads and bridges. They require evacuations that can separate people from their homes, from their loved ones, and from their medication. They can cause stress and financial losses with losses of homes and belongings and businesses. And they can cause power outages that have resulted in deaths from hypothermia and carbon monoxide poisoning. Now, climate change is increasing temperatures across the country, and this has been more so in the north than the rest of the country. And this is expanding the range of certain vector-borne diseases such as West Nile virus and Lyme disease, but it's also giving rise to hotter, more frequent and longer-lasting heat waves in many communities. And I think this summer was a real example. I think for me, I think it was like something like 30 or 40 days in Hamilton this year that were over 30 degrees. It was crazy. So as many of you know, extreme heat is associated with heat strokes, aggressive behavior, adverse reproductive outcomes, and emergency room visits and premature deaths. The heat dome that hit BC in 2021 gave rise to more than 600 premature deaths and increased the death rate in the community by 440%. But BC is not the only province where people are dying from heat. It's just one of the few provinces that have studied it carefully. One study that examined data from 26 Canadian cities found that extreme heat is increasing premature deaths across the country by 2 to 13%. So climate change is increasing air pollution in Canada. So without wildfires, air pollution in Canada is responsible for approximately 15,000 premature deaths per year, and that's been valued at $130 billion in health-related costs. That's in a given year. Much of that air pollution is from our use of fossil fuels each summer, from our use of fossil fuels to drive our vehicles, heat our buildings, and run our industries. With wildfires becoming more intense and persistent each summer, millions of people are now being exposed to extremely high levels of wildfire smoke for days and weeks at a time. Wildfire smoke is composed of fine particulate matter. This is the air pollutant that has been most clearly and consistently linked to a broad range of adverse health impacts, including asthma, premature deaths, cardiovascular disease, lung cancer, and there's now new studies that are suggesting that it causes dementia, and it's been linked to breast cancer in a few studies. So the effects, as the evidence, as the research is done, the broad range of effects become bigger. But wildfire smoke also includes volatile organic compounds from trees and a vast array of toxics from structures and equipment that are being consumed. So we really don't understand the full impact of wildfire smoke. So one new study found that smoke from wildfires in Canada in 2023, so this is just 1 year, that air levels of PM fine particulate matter it increased air levels of fine particulate matter across all of North America and even in Europe. And then they estimated the premature deaths associated with that, and they came up with the number that the wildfires in that 1 year alone were responsible for 5,400 acute and over 64,000 chronic deaths in North America and Europe, and with 1,300 acute and 8,000 chronic deaths occurring in Canada. That study also noted that those wildfires consumed 15 million hectares of forest and released massive amounts of greenhouse gases. So climate change is increasing food and water insecurity in Canada. Rising temperatures, droughts, floods, and rising sea levels are decreasing crop yields, encouraging pests, and promoting toxic algal blooms. Intense rainfall, rising sea levels, and floods can also contaminate groundwater and surface water, while droughts can deplete water supplies. These shifts in climate are being felt particularly hard in Indigenous communities that rely heavily on traditional food sources and that are already struggling to provide their residents with safe drinking water. I think I went too far there. Hang on a second. I did. Nope. Sorry, hang on a second here. Lost my place. Oh, it's interesting. Okay. So, hang on one second here. Dear me. Okay. So climate change is increasing temperatures. Increasing temperatures are also melting permafrost that covers 40% of Canada's landmass. Melting permafrost can disrupt essential services, transportation routes, and access to food and water supplies in northern communities by damaging buildings and infrastructure such as roads and water pipes. It can also contaminate water supplies and release infectious diseases and toxics that have been stored in frozen plants, animals, and soil for thousands of years. There it is. Sorry about that. So climate change is also harming mental health. Several Canadian studies have documented post-traumatic stress disorder among people who've lived through extreme events such as wildfires, floods, and hurricanes. A few studies have reported a deep sense of loss among those who find their homes, their communities, and way of life disrupted by the changing climate. Again, this is particularly true in Indigenous communities. Canadian and international studies have documented grief and anxiety among people who are just concerned about what climate change is doing to the world and what it means for the future. This is particularly clear for young adults. See if I catch up to myself here. So climate change is also amplifying health inequities in our society. Some groups are more sensitive to environmental stressors such as extreme heat and air pollution. This includes young children, pregnant women, older adults, people with pre-existing health conditions such as diabetes, cardiovascular disease, asthma, and schizophrenia. Some people experience greater exposure to the impacts of climate change, such as extreme heat. Think about people who are unhoused, about outdoor workers, migrant workers, or people who work or live in buildings that are not air-conditioned. In addition, many people in our communities do not have the resources to protect themselves or to recover from events such as heat waves, floods, and wildfire smoke. And there are populations in our country who are at greater risk of falling into all three of these categories. For example, people who live on low incomes, newcomers to the country, single mothers, and Indigenous people. For example, research into the BC heat dome found much higher death rates among those living on low incomes and those living in homes that were not air-conditioned. So this is a graph here that shows that kind of the emissions from the different sectors in our society, like different sectors of the economy. And it illustrates emissions from 1990 through 2023, so over 33 years. The bottom one, the red columns, in 2023, the oil and gas sector, so that's the red columns at the bottom, they were responsible for 30% of our emissions in this country. Those emissions are from the extraction and refining of oil and natural gas. It's not from the use of oil and gas. Note that these emissions have increased by 77% over 33 years. The transportation sector, which is the next column up, the steel blue column, is the next single largest source of emissions. So the transportation sector is responsible for 23% of emissions. And this is from the burning of fossil fuels in our vehicles. These emissions have increased by 33%. The building sector, the darker blue columns that are kind of in the middle, has increased by 15% over the last 30 years. This is largely from the burning of oil and natural gas to heat the air and water in our homes, offices, and institutions. And the green columns are for the electricity sector. Greenhouse gases have actually dropped from this sector by 44% over the last 33 years, largely because of the phase-out of coal-fired power plants in Ontario. Subsectors such as the healthcare sector are not included in this analysis, which is from Environment Canada, but research has demonstrated that it's responsible for 4.6% of the greenhouse gases emitted in Canada. And that could be out of date. I'm sure there's people here who can correct that if it is. So a number of studies have demonstrated that the policies and investments that are needed to reduce greenhouse gases can actually produce significant and immediate health benefits, and those health benefits will be realized by the jurisdiction that acts. So investments in policies that support public transit, cycling infrastructure, green buildings, renewable energy, urban green space, these can produce health benefits by reducing air pollution, increasing levels of physical activity, improving mental health, cooling our homes and workplaces, increasing affordable access to jobs and services, while also reducing greenhouse gases. The health benefits can help win support from the public and decision makers for climate policies and investments. In part, this is because it's easier for people to appreciate the immediate and localized health benefits associated with climate action than it is to grasp the long-term and global benefits that result from cutting greenhouse gases. I personally saw this in action in Ontario over 20 years ago, and then again in Alberta 10 years ago when we were working to phase out coal-fired power plants. It was the health benefits resulting from the reduced levels of air pollution that won support for those policies in both cases. Now, the power of the health frame of climate change has been demonstrated with several peer-reviewed studies, but one in particular found that the public can be motivated to support climate action when presented with three things: the health risks associated with climate change, the health benefits associated with the climate action, and clear calls to action. When those 3 points are combined, the study found they can influence people across the political spectrum. So this is something that's incredibly helpful given the very polarized nature of climate change discussions these days in our country and others. So with most climate actions, there will be immediate health benefits for some members in our communities. However, if we want to reduce health inequities, we need to do that with more intention. It requires understanding which populations face the greatest health risks and where they're located. For decades, it's been recognized by health professionals that social environmental factors such as income, gender, immigration status, and housing have a significant impact on health. We call these the social determinants of health. In more recent years, it has been clearly articulated that these factors are shaped by the interpersonal and systemic biases that exist within our society, such as racism, sexism, and colonialism. By prioritizing investments in neighborhoods that are home to these disadvantaged populations, we can correct for social injustices, reduce health inequities, and have a greater impact on the overall health of the residents in our communities. This thinking applies to the actions needed to improve climate resiliency as well. So as health professionals, we have an important role to play in educating the public and promoting actions needed to address climate change. This is because we are trusted messengers who are deemed to be independent and knowledgeable about health issues. Communication surveys tell us that the Canadian public is very concerned about climate change, but they're very confused about what the solutions are. As health professionals, we can help the public to understand that climate change is harming their health, the actions needed to address it, and the health benefits associated with those actions. Many of us are in a position to educate patients about the health risks, and then the actions that people can take to protect themselves. Those who work in healthcare facilities and educational institutions can promote actions that increase both the climate resiliency and the sustainability of their organizations. And all of us can advocate for climate action and climate resiliency within our communities. We can use the health risk that climate change presents and the immediate health benefits that can be gained with support for action. With all of this work, it's essential that we advocate for the prioritization of populations that are at greatest risk. So I'll just point out there's some resources here and some links to them that you might be interested in. And otherwise, thank you very much for your attention.
We're going to sit down and have a little chat for a few minutes, if that's okay. I know it can be unnerving when your PowerPoint doesn't cooperate, so thanks for getting through that. Now, Kim, you've been at this a long time. Are the politicians or the policymakers, are they starting to listen?
I think we're kind of, well, speak to it. I think we're actually going through a really dark time where the politicians really aren't listening, and I think that's a real problem, and I'm sure that many feel that. I think also we're going through a time of incredible misinformation that fossil fuel companies are funding, and so that the public is actually starting to kind of second guess what's needed. And recently a communications survey actually found that the concern about climate change in the Canadian population is dropping a little bit. And then the other thing that communication surveys keep telling us is that people in Canada are so concerned about climate change, but when they ask where the investments should go, they always say fossil fuel infrastructure as well as renewables. So the public they're being kind of influenced by social media and by very powerful forces. And I think that's where, honestly, I have seen it. My time with CAPE was really inspiring in the sense that it's really possible as health professionals to have an impact on decisions, particularly at a local level right now. I think we've got a lot of provinces that are not really going forward, but there's still a lot of really good work going on a municipal level, and I think that's really easy to be influential at that level.
But you talked about some victories with coal-fired plants. Is that the magic formula to talk to people about this is really about your health? It's not about oil or climate? Or...
I think it is. And I think part of that is health, that people, again, studies tell us that people are most concerned about health, and that's kind of just something, especially the health of their families. If you tell them that's health of their families. But I think the other thing, when we talk about climate action, people keep thinking, well, that's something that's going to happen in 2050, and it's only going to happen if China pitches in. Whereas when I think you can talk to people and say, if we shut these coal-fired power plants in our community, air pollution will be down, and it'll be your children and your grandmother whose health is improved. That really resonates with people. And I think the other thing I just want to say is health professionals. I think this is more so for those of you who are healthcare professionals. As a public health professional, I've been kind of trained to use statistics and studies. But what we know, again, is that what sways people are stories, that it really reaches people when you tell them stories. And many of those of you who are healthcare professionals have real stories that you can share with people. So, you can tell somebody that you've seen somebody come in on a poor air quality day, or when the wildfire smoke is going, and it's a child with asthma. That kind of thing resonates with people, and that's where you don't need to be an expert in climate change. But I think as a health professional, you can bring real life stories to people that help make what we're doing to the planet real for people.
And it gets real when we open our windows and the smoke comes in every day.
Yes, absolutely. Yes. And I think for us in Ontario, I find every province is a little different in terms of what we experience. In Ontario, it's often the heat and sometimes flooding. Now for us, it's West Nile virus and Lyme disease, which, now that's becoming kind of commonplace in Hamilton, for example, where I live. And then out in the west, it's wildfire smoke, and that's now going on. Like I remember several years ago watching the AQHI, the Air Quality Health Index. During wildfire smoke, we were getting levels that you never saw from industrial emissions. So, we're really talking about very, very high levels that are very harmful. And I think for people it's becoming real. And I just want to point out one thing. There was another survey that was done recently that said that people who've been through an extreme event, you would think that they would be more supportive of climate action, and they aren't unless they actually believe the extreme event is caused by human-induced climate change. And so we have a job to do there in helping people to make that connection. I know it seems very counterintuitive, but yeah, so people need somebody they trust, and again, health professionals are still quite trusted. So they need people they trust to help them make these connections.
Now in your slides, you outline many causes of climate change. Is there one that we should be more worried about? Can they be prioritized somehow?
Okay, that's kind of an unfair question. I think
that's what I'm here for, unfair questions. Yeah.
I think that we all recognize if we've got one sector that's contributing 30% and its emissions have gone up 77% over the last 30 years, clearly we need action from that sector, and that is the oil and gas sector. And the problem, they are getting a lot of our tax dollars as subsidies, and they're very powerful, and it's very hard for our governments to stand up to them. But I think that absolutely has to be done. And I just want to say on this point too, kind of looking here at the elder who's sitting in front of me, I want to acknowledge that the oil and gas sector does have a very direct impact on people in the north and on Indigenous communities. They get the direct impacts from the extraction processes related to oil and gas. And so I think it's also important to keep that in mind. So I think that's one source. But I would also say we need everybody to work in every sector right now. So I think wherever you can work, wherever you feel you can have an impact, if that's fighting for cycling infrastructure in your city, then go for it. If it's trying to get better bus service for low-income neighborhoods in your neighborhood, I think every one of those things has to be done.
And you mentioned the equity question. Climate change is not an equal opportunity killer. Can you expand a bit on that unfairness?
Yeah, and I think I mentioned one of them in terms of, there's the northern and Indigenous communities that are really hit by fossil fuel extraction. First of all, there's an equity issue there. And then there's the big global picture, which I was mentioning. We are a very bad performer. And there are people dying of undernutrition and food security issues around the world because of our emissions. I think we have to own that as Canadians. And again, Canadians don't believe that. They think we're a good performer. And again, communication surveys demonstrate that. But then the third one is just within our communities. It's really important, if you look at something like a low-income neighborhood in Toronto, for example, they're more likely to have less access to public transit, even though they probably need it more than a richer neighborhood. They're less likely to have a walkable neighborhood that's good for their health and that gives them easy access to food. They're less likely to have a good tree canopy, easy access to parks. And so those are the kinds of things that at a community level we can kind of address we can do that both when we're fighting for climate resiliency, say that we want more tree canopies to go to low-income neighborhoods first. And we can also do that when we're fighting for climate mitigation. If we want investments in public transit, let's say that we want that public transit to provide greater service to the lower income neighborhoods in our communities that are actually relying on it more. So those are they're small arguments to be made in many, many places.
And when we see things like the heat dome in BC, we know that the victims were all low SES, older people. We know who's impacted by this.
Absolutely, yes. And for every issue, it's a little different. But yes, that's absolutely true. So, yeah, I can't remember the death rate, but the death rate for low income was much, much higher than for the higher income people.
And you mentioned, oil and gas has a big impact, but we're talking today mostly about the health sector. And we'll talk about it more in detail later, but that's not negligible, 5 to 8% of emissions.
It's not, and I think I'll be honest right here, I'm not a healthcare sector expert, so I'm going to leave that to other people today. But yeah, I think there's also something to be said for cleaning up your own house. If you're going to kind of ask other sectors to clean up their house, it's important that we kind of do our part to make our emissions from our healthcare facilities and our jobs to reduce those. I mean, I think it's kind of good sense to do that.
So lead by example is your message today.
Yes, that's part of it, yes.
Now, the last thing I want to ask you, I go to a lot of these presentations, they're depressing. Let's be honest, they're depressing. There's lots of eco-anxiety, especially in younger people. How do you stay hopeful when you talk about all this stuff all the time?
I was really fortunate. So I'm old. I've been around doing this work for 40 years. So I was really lucky that I was actually working for Toronto Public Health, and I was assigned the coal-fired power plant assignment. And so I worked on coal-fired power plants for Toronto Public Health. Then I went on to do it for the Ontario Public Health Association. Those coal-fired power plants were responsible for 25% of the greenhouse gases in Ontario, which at the time was the greatest emitter in terms of provinces. It also was responsible for something like 50% of our sulfur dioxide, 25% of the fine particulate matter. So when we closed those down, not only did we reduce greenhouse gases from Ontario by 25%, we also reduced premature deaths by 400 people per year. So it's been this incredible thing, and air levels of sulfur dioxide have dropped way down, as have fine particulate matter with the closing of coal-fired power plants. So for me, I just want to say that my job there, I was working for, I was bringing forward the health arguments, but it was really wonderful that there was a whole group of people who got together, and there was a Sierra Club, there was a Cottagers Association, there was the Lung Association, and we all brought forward different arguments and took them to different audiences. So, the cottagers talked about acid rain killing off fish, and we talked about air pollution, and Sierra Club talked about climate change. And we never did it as a whole. We never kind of called ourselves a name. And I have to say, the OMA at the time, the Ontario Medical Association, did an incredible job. They would hold monthly meetings, and they did that for years. And we'd all go there, and it was Michael Purley at the OMA, the incredible strategist. He would say, okay, so who's got something happening this month? And then if it was my report, he'd say, okay, so give Toronto Public Health this month. Nobody else speak out. And so the idea was to kind of pepper the public and the media with one story after another, coming from different voices and focusing on different issues. It was incredibly effective. And I kind of feel like if we can close down coal-fired power plants in Ontario, we can do just about anything.
And last thing, you and I were both old, but this is something that young people are really passionate about. Does that make you more hopeful?
Yes, and I also feel I'm one of those people, because I work on kind of the climate change movement, kind of on the edge a little bit. But I am so impressed. Young people today, they are so much better educated than us. They're so much more skilled. They get on these virtual meetings with, 80 people, and they all speak up. I'm sitting there, and I'm really shy to say anything. I'll chat and that. I feel like these are young. They're bright. They're well trained, and they're passionate. And they give me hope. Yeah.
Great. A good note to end on. Kim Parada, thank you very much for joining us.
Thank you.
Thanks. Now, I'm just going to step aside for a second while they bring us more chairs. And I get my notes. So, now, Kim did a wonderful job of providing us the big picture and some context for today's discussion. So now, next up, we're going to do a little deeper dive into patient and health impacts. We have a great group of speakers, including some young people that we were just talking about. So let me introduce them, and they can make their way to the stage. First, we have Dr. Ogisto Ganawahe Horn, Medical Director of Health for the Mohawk Council of Akwesasne. Welcome. Next, next, we have Dr. Julie Sawatsky, an emergency medicine resident physician with the University of Alberta. Julie is also co-chair of CAPE Alberta. CAPE stands for the Canadian Association of Physicians for the Environment. Welcome, Julia. And also joining us for the panel is Cecilia LaRose, a youth climate activist. She was the lead plaintiff in LaRose versus His Majesty the King, a landmark youth-led constitutional climate lawsuit against the Canadian federal government. So welcome. Okay, who doesn't have a mic? Dr. Horn. Great. At the Globe, we have very modest chairs here. I hope it doesn't feel like a CIA interrogation, but... So, I want to start, if I could, Cecilia, we were just talking about young people and how they give us hope, so lots of pressure on you. But you have an interesting backstory. I want to hear a little bit about it, but I understand you quit traditional high school, you became a full-time climate activist. Why does this issue matter so much to people of your generation, that you do things like this?
Thank you for having me. High school for me was difficult for a number of reasons. Climate change and my work in the advocacy space was part of it. In 2019, I was very entrenched in the Fridays for Future movement, which it was, I would say, when young people entered the global conversation on climate change.
So Fridays for Future, to remind people, that's Greta Thunberg?
It's Greta Thunberg, yes. And so in 2019, I ended up joining this lawsuit, and that brought together young people across Canada who were interested in pursuing their legal rights to life, liberty, and security of the person. So we were alleging that our charter rights were violated because the government of Canada was contributing to dangerous climate change.
And how's that going? It's been ongoing for a while, like many lawsuits. Where's it at?
So the pandemic slowed it down. We very quickly made our way to the Federal Court of Appeals, where a motion to strike was granted. That was overturned in 2024 unanimously, and we've been granted the rights to an 8-week trial in October of 2026. So right now we're preparing for trial.
So it's only been 5 years and it's almost getting there.
Only 5 years.
Okay, yes. Well, our legal system goes a little slowly sometimes.
It's slowly but surely.
Great. And we'll come back to some of those issues that you raised and more. Dr. Sawatsky, welcome. Now, you're a resident doctor. That's a very busy time already. You have a lot to do already. So why do you get involved in things like CAPE? Why do you take the time out of your career to do this?
Well, so I got involved in climate change and health and in CAPE initially as a medical student, and in many ways I feel like I got involved because I had to, because I was seeing things when I was seeing patients and in our communities that I could see were related to climate and environmental change, and I was deeply worried about it and wondering what we as a healthcare community and we as doctors could do about it. And it became very clear very quickly, as I think it becomes to a lot of people who enter climate work, that it can't be done alone, that there are big structures of power and big issues that we're up against. And so getting involved with CAPE was really about finding a community of people who cared and people who had the courage to speak up and to challenge some of the root causes of what I was seeing at the bedside and with patients. And now I find, it really fuels me to get a chance in my extracurricular work with CAPE to chip away at some of those problems and be among people who see healthcare and see what's happening to our patients with that broader lens of the ecosystems that sustain us, the pollution that harms us, all those types of things. And I think now, to me, there is no one without the other. And I think I'm part of a generation of doctors and a community of doctors who are really seeing it that way, that it's inseparable. And so the work feeds each other.
So let me ask you the type of question I get when I write a column about these issues in the Globe. What does climate change have to do with medicine?
So climate change is one of many environmental disasters, or one of the pieces of planetary health, one of the issues happening in the environment right now that's impacting health at many levels, from the community to the individual patient. I think sometimes, so I'm an emergency medicine resident, and I think sometimes people in my community struggle to see how exactly it's related, because they say, what are you going to do at the bedside? How is it going to change what you do for your patient? And I have many answers to that. I think some are that we still have a role to advocate for our patients when we're not at the bedside, and actually that's a huge part of what it means to be a doctor and part of this profession, because we do have power. I think another piece is that I've had actually incredible experiences talking to patients, even in the emerge, even in a really busy place where it's not necessarily top of mind, saying to people, wow, this must be a really hard summer for you. Like, we've had fire after fire and smoke after smoke, and people kind of, they're like, yeah, it's been getting worse over the last couple of years, and people feel really seen in knowing that their doctors can see what's happening and see who they are when they're not right in front of you. And then we can counsel patients. We can give them anticipatory guidance about how things are going to get worse, how we can help them protect their health, how we can help them prepare for disasters. And so there's a lot that we can do at many levels. And at risk of going on too long, I think there's the relevance to medicine is there to be found. And there's so many levels. I haven't even touched on the sustainable healthcare piece of that, but there's a lot of ways in which the relevance is so direct and ready for us to get involved in.
Well, we'll come back to the sustainable healthcare, but I guess your message is your patient is not just the person in front of you, it's the community, it's the planet.
100%, yeah.
Now, Dr. Horn, we know Indigenous communities are disproportionately affected by climate change. How do you see this reflected in your daily practice in primary care?
So I am a Ganyakehaga, or Mohawk, from the communities of Kahnawake and Akwesasne. And so we are along the Ganyat-Darawanana, or the St. Lawrence River. And so we have been part of all of the things that have happened in Canada from the very beginning, first with the Dutch, the French, the English, the Americans, and then the Canadians. And so we have a very long memory. We also are in a very industrialized area, and we receive the waters all the way from the inner part of the continent that come right by us. And so when I see my patients, we already have this collective knowledge of having lost just about everything, in particular the health of our community, the water, the air. And so we've had to accommodate and try and change, and we've had to and adjust. But one of those things is adjusting for is all of the chronic health problems that we have, and all of the cancers. The cancers are quite overwhelming, particularly late-stage cancers, and we are trying desperately to improve our screening, but often we don't meet screening guidelines because our numbers aren't reflected in a lot of how data or evidence-based medicine is collected. Indigenous, we're actually an unknown, but then we are asked to meet a criteria. We're asked to meet guidelines. We're asked to conduct medicine like everywhere else, and we just don't have the human, logistical, or financial resources to do so. And so we do our best, and so every single part of my day is confronted with this inequity that exists, trying to meet an expectation that is very, very difficult, and also some very, very sick people with autoimmune cancers, diabetes, chronic inflammation, so many things. And so I see it all the time with almost every single patient, and the discussion comes up, and I say, what do you think is the reason for why you got sick? And all of them say it's because of the water, it's because of the air, it's because of the land, it's because of those facilities upstream. And so it's very much pollution, and that pollution is being reignited, changed, redistributed, because directly and indirectly from the effects of climate change.
But you still have to do the everyday stuff of treating.
That's right. We still have to do the everyday stuff, which is very hard because, like I said, we're following clinical practice guidelines that were not designed for our population, or with this other set of risk factors that are even taken into account, and of course the lack of resources.
Now, there's lots of health issues in First Nations communities, poverty, housing, intergenerational trauma, the list goes on. Where does climate change fit in this list of priorities?
So the things that you just described about housing, and we can talk about water, housing, garbage, waste, all of these things are really in the realm, in the way that Canada is designed under the municipal governments. And then we have the provincial governments would have all their mandates to provide different services. And then, of course, we have the federal. Well, we as First Nations or Status Indians, I'll speak for us because I am, we are covered federally. And so we don't actually benefit from many of the plans and strategic plans of the municipalities around us. We're not actually part of the emergency response plans because of climate change disasters. And so we have to do that on our own with very little support. And so these social determinants of health are not the same, they don't have the same support in how it was built up and maintained. Don't forget, a lot of our communities were never designed for long term. We were not supposed to stay there. We were supposed to leave and go to cities and become assimilated. We're not supposed to stay in our communities. That was the design. And so now we have an infrastructure that has broken down, and a lot of our people don't even have clean drinking water, and we do not have the economy to be able to support ourselves, and we also don't have access to a lot of our resources because they have been damaged because of the pollution. And so the social determinants of health is what underlines the things that you were mentioning, but they are exacerbated because they were initially designed with very poor long-term reach or sustainability, and now we have all of these other concerns. Most importantly, waste management is a huge problem because that is how we make money. We allow people to dump into our communities because we don't have, who's going to come and spend money in our reserves unless you go to a casino or get some smokes or go get cannabis, or we have a lot of sex trafficking. We have lots and lots of problems because how do we get people to come to our communities and spend money? We've lost our tourism because of all of the pollution. So what are we supposed to do? And so I would say that history has caught up, and the jurisdictional issues and all of the different laws and the way that Canada was set up has now caught up, and now we are now talking about climate change. I wanted to say the waste. We get paid for that, but that waste, that landfill that's being dumped in Six Nations, or all of that concrete from Montreal that's being dumped in Ganazadage or Oka, all of the gravel and the pits that's coming from my community, all of this stuff is being done without the same environmental regulations that the rest of Canadians enjoy. It is actually community specific, and we are supposed to moderate, we're supposed to hold those companies accountable to what they're dumping, and we actually don't have the resources to do that well. And so we have a buildup of waste, and of course it goes into our groundwater, and of course our children are playing in it. And so these are all they all add up, and unfortunately we end up with this situation where our health is very, very affected.
Right. And we'll come back again to some of those issues. Cecilia, I want to come back to you. How do you talk to people who aren't on the surface interested in this issue of climate change? How do you get them on board? Is it different with younger people, older people? Do you speak differently to different generations?
I would say stories. I speak to a lot of different people about climate change, and for me, it's the connection between the personal and this very abstract perspective that we have on climate change right now. It matters that people speak honestly and that they speak personally about their experiences. I think we're at a point where apathy is quite common, especially among young people. Breaking through that, I honestly don't know what's going to do it. I think we have to keep pushing at it, but right now is a particularly hard time to be having those discussions.
But there's kind of this dichotomy. There's the very passionate and then the very disinterested. So tell me a story that's going to change our minds here.
A story that will change your minds. I can only speak for myself as someone who's grown up in Toronto. I don't view myself as a particularly hard done by person. I come from a family of immigrants, and for me, climate change, my earliest connection was thinking about my family in Guyana, my family who live on a reserve, who are not afforded the same opportunities that I am to file a lawsuit, to come and speak on this stage, who face the impacts of climate change in a way that I can't comprehend, that people in this room can't quite comprehend. And for me, my early days in climate action, in preparation for this panel, was looking back on it and reading some of my old pieces. And it reads as a bit of a panic response. As a young person who didn't really know what to do with quite big emotions around this existential dread that seemed to take over. And so I look back on that, and that's the only way I can rationalize it. I'm in a very different position now. I'm much more comfortable talking about it and thinking my way through climate change. But yeah, it's something that I worry about young people now who are growing up in a slightly different climate and don't necessarily have the same opportunity to process those emotions.
And we heard that earlier, it's not getting easier.
It's not getting easier now.
So how do you deal with this existential dread, this eco-anxiety? How do you deal with it?
Like I said, it was being able to channel it somewhere. I was very lucky that I was surrounded by adults who were attentive and really pushed me towards advocacy, who encouraged me to speak about myself and connect with other young people. That's where I still am today. But yeah.
Dr. Zawadzki, I know you don't have a lot of time for chit-chat in the ER, but how do you talk to patients more generally about these issues? How do you incorporate it into medical practice, not necessarily in the ER, but overall?
Yeah, I mean, it's something I've been working more on lately because it is top of mind for me, and I think a couple of times I did experiment with talking to patients and it actually went really well. And working in Alberta, like I would have a I Heart Climate Action button on my lanyard, and it was actually met with like really good responses by and large. Like people would often acknowledge it or smile at it or say good luck with that. But they, there was certainly still engagement with it, and I think that helped me to see, because at that point a lot of my advocacy was outside of the clinical space. Like I think what feels better for me when is talking about climate, and I spend a lot of time talking with my communities. And as you were talking about climate grief and anxiety, that's where we often find solace is in community. And so it just felt natural to me to extend that to patients. And kind of like I was saying earlier, especially in these hot, smoky summers, trying to just draw in the broader context to patients and to say things that doctors are trained to say anyways, like to say, I can imagine that this has been very hard for you, or I can't imagine what it's been like to live with severe asthma in a smoky summer like this, or to find ways to identify that you're thinking about them out in this world, because in Emerge, we are going to send them back out into that world, right? Without often altering the situation in which they live, whether that's low-income housing where they don't have air conditioning, or for so many of our patients in Edmonton's inner city, they don't have anywhere to live and they're going to be sleeping outside in the air, to comment on that and to not, because I think it does no one a service to not acknowledge that this is affecting them, and it allows people to see themselves as part of the story. I often will also say, on those smoky days that I noticed on my way to work that my throat was scratchy and my eyes were watering, and it just, I think, helps to bridge the divide and bring us closer to patients, and that this is like really a common struggle that's woven into the fabric of society. And so it's not just about patients, it's not just about me, like it's really to see it as a common thing. And then the only other piece I would say to that is where I can, I try and help patients understand what information they have. So using things like the WeatherCan app to check the air quality and to know how to use that information, which is the bit more kind of actionable piece that I think we can try and help patients stay out of the emergency department and give them the tools to live and function in a changing climate. But yeah, when I talk to colleagues about that, I'm often met with the idea that we don't have time for that, or that's not our lane. And I think a big part of the work is pushing back against that and saying this absolutely is something that's going to affect our patients, and we have to take the time.
Now you've got your I Love Climate Action button. How do you interact with the guy with the drill baby drill button?
Yeah, I just kind of turned my lanyard around. No, but that is an important exercise too, right? And I think, again, medicine has been a privilege of a place to come to this work from, because even before I got into the climate and planetary health thing, I came to medicine wanting to learn to care for people and to empathize with people and to meet people where they are. And in many ways outside of this issue, that can be challenging, and you often come have to come ready to really try and use your empathy imagination to see what worldview shaped that. And so I did some work recently up in the oil sands region and working in Fort McMurray in particular. And so that there I knew that the identity of the place and the formation of the place is so linked to an identity of fossil fuel extraction that I was going to have to, continue to do my work and to be inspired by what needed to be done, but also really see the humanity in all the people who were working there, who believed in that, and see, if there was any common ground to be found. But yeah, it's not always easy to engage with those conversations.
And Dr. Horn, we're mentioning, it's not getting easier these days, these discussions. There's a lot of talk of the economy, all kinds of nation-building projects. Ontario has its Unleashing Our Economy Bill 5. Even in your communities, there are people who own these dump sites, for example. How do you counter that economic argument with health arguments?
So the reason I have spent a lot of time talking about C5 with my patients and in the community is because we're all talking about it. There are many groups in the community who are from different points of view are talking about their concerns. So this is actually a very much grassroots of which I'm part of. And so lots of robust discussions. What I'm very concerned about is not just that, there's this push to, get resources from the north. What upsets me is that we are not taking into account those externalities, like the land and the health of the land, environmental pollution, and the Indigenous people up there. It's been something that has been done for the last 150 years, where Canada has gotten its natural resources from these northern areas, and they have not invested in the people around there. And so the people have not benefited. they've just been left with the legacy pollution that's been left there. Or they go to these big man camps, and these man camps are not designed in a healthy way to provide, really good relationships with the surrounding Indigenous communities. So we have a lot of drug and alcohol problems, as well as sexual abuse and prostitution of Indian women, which only adds to the big narrative that we're now talking about murdered and missing Indigenous women and girls. So I'm very concerned that we're having this big discussion about going up north without any discussion about these externalities. How are you going to actually go ahead and do that? Shouldn't you be talking to the Indigenous people up there? Should you maybe not do what you've been doing for the last 150 years? Because we've shown you that this is not acceptable. In our community, what is also a big concern is there are a whole new number of new industries. We've got cryptocurrency, we've got AI, artificial intelligence, and these require incredible amounts of energy. And so in our community, we are dealing with, we have a dam, we have water, hydroelectricity. We also had to fight off a hydrogen plant from being built. We were very concerned about that and how it hadn't taken into effect how it was going to distribute all of the sediment at the bottom of different places and redistribute all of the old PCBs. So we were really, really concerned about that. And then just recently there was a discussion of putting a nuclear power plant there. And so, we keep getting confronted because right now there's this push, we need more energy, and we happen to be in a place that's infrastructure rich for this kind of energy. So we keep having to fight it. So it does take a lot of energy, and we have to always be up on top of things. But what concerns me is that these legacy pollution that I've talked about this morning is concerning because, for instance, where we are, it's PCBs. And PCBs, as we know, were banned in 1979 because they were found to be carcinogenic. And certainly we have a lot of problems because of the PCBs now with a lot of our people having cancers and autoimmune disease and, their endocrine disruptors, so fertility and other issues. Like, it's just a lot of baseline risk. But with the heat and time and the anaerobic bacteria, those PCBs have gone from the older type and they have changed, and now they are a lighter airborne type. And because of the heat, they're putting these big fans on the cryptocurrency servers and to push all the heat away from them, and it's just pushing mechanically these PCBs into the air. And so we did a tree bark study to look and see if the PCBs were in the tree bark around the community. And we found, yes, they are in there. So we know we're breathing it in. And we know that it's probably getting worse because the exposure is getting higher because recently this particular plant got the go-ahead to massively expand its works without any consultation by us. And the reason is because of jurisdiction, because we are right on the border of Canada and the United States, and in Canada we have the Ontario-Quebec border going through us. So we have all these jurisdictions, and corporations work best within the gray zones of accountability because of the jurisdictions. And so how are we, an Indigenous community, supposed to, hold the American companies accountable to the legacy pollution and the risk of its disbursement with all of these new projects? And so we really do talk about jurisdiction where I live, as well as pollution, and as well as this long-standing colonial relationship with all of the things that happened here, even before Canada was here. So we have a long memory, and so this is not a new discussion.
And I talked at the outset about... At the outset, I mentioned in passing TRC number 92, we shouldn't have development without input from Indigenous communities. Obviously, that's not happening.
Yeah, so I brought actually a wampum belt. So I'm going to. So we've been talking about the United Nations Declaration on the Rights of Indigenous People, and actually, if you look at it, it is actually the same tenets, the same discussion regarding our original relationship that was first with the Dutch, then with the French, then with the English, then the Americans, and the Canadians. But it really is solidified in this wampum belt, which is in 1764, and this was the Treaty of Niagara Wampum Belt, and what it did was it affirmed and discussed and ratified the Royal Proclamation of 1763. And in there, it was that we were going to be brothers, not father-son, and that we were going to work side by side, and that we needed to be part of all of the decisions that were going to be made, and our affairs were our affairs, and that we had a right to be able to take care of our own affairs without being, molested by outside entities. And that's what we're seeing now, a complete negation of the things that were previously agreed to. And then, and the agreement was we weren't going to attack their villages. So I think that, we kept our side of it up. So here now we have United Nations Declaration on the Rights of Indigenous People, and it's saying the same things that we've been talking about for 250 years. So this is not new, and the fact that we were not consulted for any of this discussion, for all of these bills to go and get resources, is a huge lack of obligations and responsibilities that they had previously agreed upon and continued to agree upon and were reminded of for UNDRIP, and they still forgot.
Cecilia, I want to come back. You saw the presentation, the background presentation of all the things that are contributing to climate change. I want to ask you the same question I asked him. Do you prioritize some of those? Is there something that's more important for you? Is it the oil sector? Is it the hospital sector? Indigenous communities? How do you prioritize your action?
Wow. It's hard to pick. I think at this particular moment in time, Indigenous people need to be at the forefront of this conversation, Indigenous youth particularly, who have been talking about this for a long time. In Canada particularly, we've had some reckoning with what we've done as a nation. I don't know if it's expanded to an international conversation about Canadian oil and gas companies. When people talk about our emissions, we're talking about domestic, but our coal exports are just astronomical. Our oil and gas companies that work in places like Guyana, where none of that money goes towards communities, we're global exploiters. We really take advantage of our perspective and how we're seen on the global stage, which is quite kind in comparison to how I think you'll find many Indigenous people across the world, particularly in places where our oil and gas impact them, talk about us, which is less kind.
And I want to ask you a little bit about the theme of the day. You're a young person, you're healthy, you don't interact a lot with the health system. But do you think about that? You see your local hospital with the big smokestack. Do you think, what's the environmental impact of that sector? Or do you have other things that are more top of mind?
I don't work in healthcare, so I interact with it as an outsider. I think about that with industries in general. I don't find that healthcare is something that's particularly spoken about, and so it's not something that crosses my mind as often. I do come from a family of people who work in science and in healthcare, and I see the changes that happen on the ground and just how much people are tasked with already. It's very hard to imagine adding to that in people's everyday lives, but I think about it, yes.
Okay, well, stay healthy and stay out of the health system. That's my advice as an old person. So I want to ask you, I have a couple of minutes left. Again, I want to end like the last discussion is, how do we remain hopeful? And Dr. Horn, given all the issues you talked about, how do you remain hopeful looking forward?
So when the original studies that happened in our community, of which there were many, but the original one came from a question from a midwife, my Auntie Gudgie Cook, and she said, with all of these PCBs, is it still safe to breastfeed? Is there, PCBs in mother's milk? And so they did this study and found out, holy, yeah, there's actually a lot of PCBs, and the biggest load goes to the very first child. And so then the question is, well, is it safe to breastfeed? And so this started, a whole series of questions. So always asking questions is the way that you stay hopeful. The question is, why? And then prove it. And so we need to provide the space and the resources for our own people to ask those questions that really are important to us, so that we can actually have hope that we can make change, and that we will know that we were part of it.
Great advice. Journalists like hearing that one. Ask questions. Dr. Sawatsky, how do you remain? You seem an upbeat person, but how do you remain hopeful?
Well, I think a huge part of that for me is people and community that I work with. And so just being here today, I am massively standing on the shoulders of giants from CAPE. Like, this room is full of my heroes who are doing this work and have been doing this work a lot longer than I have, and who I wasn't taught, I don't think, in my conventional medical education about advocacy and about speaking truth to power and having courage and calling out injustice and really asking who has power, who has influence, how do we disrupt that? But I know people who have been showing me the way and who have been teaching me that really experientially by bringing me along in organizations, building bigger tables, saying, let's write an op-ed, let's talk to the media, really leading the charge on speaking up. And sometimes it is really hard to wonder if that's doing anything, or if, but just the fact that it's happening, that people continue to do that and to look to each other and support each other in doing that work and having that courage, gives me immense hope. Yeah.
Cecilia, how do you remain hopeful? You've got a lot to look forward to, many years. How do you remain hopeful?
I don't know if I need to be hopeful. I'm invested in this. If I didn't think it was worth it, I wouldn't be on this stage. I hope hope comes later, but at this moment, I'm just kind of focused on moving forward.
You don't have to remain hopeful, you have to give us hope.
I wanted to say that there's a lot of work towards encouraging our people to go back towards culture and land and traditional-based types of healing. So this is actually what provides us hope. When we start to participate with the land again and with each other and do ceremonies that remind us of our roles and our responsibilities to steward the earth as per our original instructions, when we are allowed to do that and supported, that's when we are going to feel hope and a sense of meaning and purpose and belonging. And so supporting everybody to start to participate with engaging with the earth and all of the things that she has will provide us with hope.
Great. And your previous comment, ask questions. I got so caught up in our conversation, I forgot to go to audience questions. But now's the time for the nutrition break and networking break. So I apologize for the lack of questions. We'll try and, if you send them in, we'll try and send them to our individual panelists. I know they're all very engaged. Make up for it that way. My apologies. But please come back at 2:30. Enjoy. There's always great food at the breaks here. So enjoy and come back and meet some people. Thanks. Hi, we're going to get started again. If we could sit down. So welcome back. We're going to get started. Good. Yeah. Thanks. Thank you. I hope everyone enjoyed their break. We can have a seat and get back. It's great. There's some such active networking going on. So, thank you. Welcome back. Hope everyone enjoyed the break. I thought the food was good, as it usually is. I hope you enjoyed it. Now, before the break, we heard about how climate change is impacting patients and community health, and we got into some solutions as well. During the second half of the program this afternoon, we'll focus on building capacity and knowledge among physicians and care providers, and how healthcare can operate more sustainably. We have two guests on deck for our first session about capacity building. Joining us from Montreal is Dr. Prativa Barao, Assistant Professor with the Department of Global and Public Health at McGill University. Welcome, Prativa. And also joining me on stage will be Dr. Samantha Green, a family physician at St. Mike's Hospital and Inner City Health Associates. Samantha is also an assistant professor at the University of Toronto. Welcome. We'll watch people trickle in after the break, but we'll get started. So, Prativa, I want to start with you, if I could. I want to ask you about emergency preparedness, because we heard this morning about all these emergencies coming. So it got me thinking, are we prepared for emergencies, with all these climate-related issues? Are we ready?
Short answer, no.
Okay, next question.
I think, so I'm an epidemiologist by training, and so a lot of the work that I've done in the last several years has been to think about how can health systems be better prepared to respond to emergencies. And that includes both infectious disease outbreaks, pandemics, but more and more climate shocks, because there's a lot of parallels, as you can imagine. And I think we're in a very tricky situation now, and this was mentioned by a lot of panelists that have spoken before me, where not only are we not prepared from a societal perspective, there's a lot of misinformation, as we've discussed. There's also a lot of a lack of political will, but also a dismantling of infrastructure that we did have during COVID. As you'll recall, we built a lot of infrastructure. We built the ship while we were steering it. And a lot of that infrastructure has unfortunately been dismantled for various reasons. I'm thinking about surveillance systems, for example, to track diseases, to track and monitor health indicators that do shift rapidly during emergencies. And a lot of that work has been dismantled here in Canada, but also globally, which puts all of us at risk. So I would love to be more hopeful and say that we're more ready than we were before, but I think the challenges ahead are quite substantial.
But it seems so unfortunate. We spend so much in the emergency, and then we abandon it. We're going to do it all again next time, right?
Yes, absolutely. And I think that's what we're seeing, that the panic neglect cycle is what we call it in public health. And I'm sure we've seen examples of that over and over again these last few years, certainly. And so a big question that we're trying to understand with my research also is, how do we maintain that momentum? How do we build leadership? How do we advocate? How do we train the next generation of researchers, academics, health professionals to also be advocates in addition to everything else that they're doing?
Well, you have hardly anything to do.
Easy
now,
task.
Dr. Green, I want to bring you into the conversation. Part of your focus is educating doctors on climate change-related illness. So what do you tell them?
Well, we have to start with the basics. We have to talk about the way that planetary health threats, climate change among them, are already affecting the health of our patients, who is most at risk, and what we can do as health professionals. And we need to quickly jump to what we can do, because otherwise I think there is this, feeling, this sense of doom. There's this sense of not knowing how to move forward. So we have to quickly jump to what we can do, and that involves, protecting our patients from these health threats, these imminent health threats. It also involves creating a less polluting health system, and we've talked a little bit about that today. And then we also have to teach health professionals to be better advocates and communicators, because as we've heard, we are trusted messengers, and so, but doctors don't know how to be trusted messengers, and so that's part of the curriculum, that's part of what we need to teach.
So it's not just about treating, but it's prevention and it's advocacy, it's a whole package.
Yeah, that's right. Because, for example, I ran a project over the last couple of years teaching mental health workers about the heat risks in people with serious mental illness like schizophrenia. In the BC Heat Dome event of 2021, people living with schizophrenia had a 300% mortality rate. They're particularly at risk. And so we ran a project educating mental health professionals on these risks, how to identify heat exhaustion and heat stroke, what to do in that immediate moment. But obviously that's insufficient, right? Just educating mental health workers, it's insufficient to respond to this problem. So we also need to change the system, and then we need to advocate for policy change, really, ultimately, to protect people living with schizophrenia. We need, a maximum indoor temperature bylaw so that there's universal access to cooling devices. So education is definitely necessary, but insufficient.
Yeah, an issue I wrote about recently, the mandatory heat, I guess, threshold that we should tolerate in places like nursing homes and apartments. Now, in Canada, we used to worry all about the impacts of cold, and you're doing now a lot of research on extreme heat. Can you talk a little bit about, like, beyond schizophrenia, older people, people with chronic illnesses, all of them are very at much higher risk now with climate change?
Yes, I mean, cold remains a risk, of course, and, the BC Heat Dome event, that was Canada's deadliest weather event in history. And in Canada, heat is the biggest threat that we face from climate change on the health of people here living in Canada. So, yeah, we know that communities that are already more marginalized are most at risk. Racialized communities, people living in poverty, the very young, and then, of course, the very old, and in particular, isolated seniors. And so that's why we need to educate health professionals. Doctors, nurses need to be aware of these risks, need to be proactively reaching out to our older patients during these extreme heat events. And then that's also why we need systems change, because, those isolated seniors are the hardest to reach. Education programs will not be enough to protect those isolated seniors.
Now, Prativa, I want to come back to this emergency preparedness. We're very reliant on, say, Canadian forces, reserves. Is that sufficient? I've seen some stuff you've written about the need for more of a civilian reserve, for example. Is that what we have to do to prepare?
Yes, so the idea is that during COVID, as we all know, when we needed a lot of surge capacity support, we relied on the Canadian Armed Forces. They played a role in long-term care homes, for example. And the reality is they're incredibly expensive, and they should be doing other things that they're more trained to do. And so what's the alternative? Obviously, we can't just rely on the health systems to take in all of that surge either. So one thing that we're playing around or experimenting with the lab at McGill is to think through these civilian reserves. So the idea is to have these locally rooted, community-rooted organizations of trained folks who are either retired, who are medical students, who are students in public health, basically anybody who doesn't necessarily have that medical training yet or will not have that medical training, but can still provide support during shocks, during health emergencies, during climate shocks. So almost like that firefighting model where instead of waiting for the military and or the health systems to absorb that shock, you have that intermediary there to kind of play the triaging role to perhaps support seniors who would otherwise have been neglected or isolated so that we can reduce the burden that falls onto health systems.
And I've heard too calls for something like a Peace Corps, like to have young people, because young people really care about this issue, to have them, go spend 2 years, for example, being a climate corps in communities. Is that something you've looked into as well?
So that is a model that we're investigating as well. But for now, the focus really is rooted in local. So that would be folks who are already embedded into the local community, because then it's easier to recruit, but also easier for them to have trust. And trust is so important during a health emergency. So instead of playing around with bringing people to different communities, it's really relying on folks who are in that community and can support that community during a health emergency.
Okay. And Samantha, I want to come back to that issue of trust is an all-important one. If you want people to trust you during an emergency, but also if you want to change their minds, they have to trust you. So how do you get people to trust you on the issue of climate change as a health practitioner?
Great question. Well, I loved what Julia had to say earlier about empathy and imaginative empathy. And I think as physicians, as health professionals, that is something that we're already trained in, we're already good at. I've been working as a family physician in Regent Park for 10 years now. And I'm about midway through my career, so just imagining into the future, I know my patients super well, they know me very well, and there is that mutual trust because, I treat entire families. And I do talk, actually, about climate impacts. I talk about the disproportionate climate impacts of meter dose inhalers, for example, with my patients. And people are actually more interested in it than maybe you might expect. I ask my patients, we're trying to move away from these very polluting inhalers. Would you mind trying a different kind that's less polluting? And every single person I've spoken to has said, oh, yeah, of course. I didn't know that this inhaler was almost the same as driving 200 kilometers in a gas-powered vehicle. Thank you for mentioning it. And I think because we have that relationship, it does go a long way.
But so let's back up, because we have a very mixed audience of different various levels of knowledge. Somebody might be saying in the audience, what do you mean my asthma inhaler is bad for the environment? Explain it a little bit.
Oh, sure, sorry. So meter dose inhalers, a certain type of inhaler contains a propellant that is a particularly powerful greenhouse gas, about 1,000 times as powerful as CO2. And so 1 meter dose inhaler is about the same as driving 190 kilometers in a gas-powered vehicle, whereas the disc, or also known as dry powdered inhaler, is much, much less polluting because it doesn't contain that propellant. So, there is room to shift our prescribing patterns. In other countries, they prescribe a lot more of those discs than we do in Canada. It's really cultural, our prescribing patterns in some cases, in a lot of cases. So there's been a move with great thanks to some organizations such as Cascades, and there's been a move to educate health professionals to switch our prescribing, and not just educate, but also try to invoke some systems change.
And that's the key. There is an alternative. You don't have to just wheeze.
Correct. Okay. Yes.
Now, Prativa, I want to come back again, you talked earlier about tracking. For tracking, you need good data. Mm-hmm. Canada, we have some data issues, as the CMA folks know very well. How are we doing on tracking?
Yeah, so that was a huge challenge during COVID as well. Everything from definitions that we were using from province to province to data sharing. Those were huge
like hospitalized
challenges.
Patient didn't mean the same thing from province to province.
Or even what it meant to be COVID positive, for example, or the number of days that you would be considered to still be positive. So there's a lot that can be done to standardize a lot of that. Some of the work that I did during my PhD actually was to figure out better ways of data collection, but also data standardization. And it's really, really tricky because during an emergency, things are shifting and things are moving really, really quickly. So not only are you dealing with the usual systems-wide issues of data sharing, data definitions, you're also doing it in an environment where everything is changing all at once. And with COVID, it was acute, and I can imagine that with climate emergencies, depending on the type of emergency you're dealing with, it could be acute or it could be a little bit more on the chronic side. So I think there's a lot that can be done. There's some models and experimentation that we've done in the past. So some of the countries that I've worked in, we looked at something as simple, but also not as simple as doing a phone call to health system managers to kind of check in once a month at a high level to get a high level assessment of how the health system is operating, what kind of resources were left over, which kind of resources were being depleted, to kind of allow then the higher levels of government to say, okay, maybe this region requires the type of resources that's currently missing. So I think experimenting with different type of models, especially in the context of an emergency, is really, really important in order to get that right. Because if you don't have the right data, then it's kind of hard to know where to allocate resources and what to act and how to act with subsequent steps. So super important.
And prior to COVID, we got rid of something important called GFIN.
Yes.
What's the impact of that been?
I feel like I can talk about that for an entire hour. So GFIN was this amazing surveillance system that Canada was known for. It was incredible in the sense that it didn't just rely on regular data that was coming in, that was sent in by governments, but also would investigate random events that were happening around the world that were a little suspicious. So for example, if there were a bunch of animals, for example, that were dying in a particular region in a country somewhere, people would go in, epidemiologists would investigate that to kind of figure out what the source of that was and see if there was something else. Was there a potential for an outbreak? Unfortunately, there were all sorts of bureaucratic steps that were added in to that system. So the signals that would ideally be déclenchés, that would ideally be given, were no longer operational anymore because of those bureaucratic steps. And also from a funding perspective, because I guess it worked so well, as in public health, we say if it works so well, it's really hard to promote or continue to invest in prevention, because then nothing happens. And so because of that, it was defunded, bureaucratized, and we need systems like that that will be helpful for health emergencies, for climate emergencies, for pandemics, because they're the ones that kind of give us the early signals so that we can actually prepare and respond appropriately. Otherwise, we're constantly having to rebuild systems every time there's an emergency, and that's a huge financial cost, but it's a huge resource cost, and just from a time perspective, it's really detrimental as well.
And that's the paradox of public health, is when you're successful, you're invisible.
Exactly.
Yeah. Samantha, we talked about trust, talking to people, but there's also this epidemic of misinformation, disinformation out there. Is it making your job harder?
Yes, it is. But thanks to the relationship that I do have with my patients and that all family doctors have with their patients, I think my patients they come to me with what ChatGPT told them or what they found on social media, but I think we almost all the time can have these real conversations grounded in reality and grounded in the evidence. And so I think that relationship, as you said, as you pointed out, is very, very important.
Great. Now this time I didn't forget, so if there are questions, raise your hand, we'll get a mic to you. Trish, if there are any questions online, you can bring them up to me. So anyhow, wave your hand for these mic folks, and otherwise I'll plow ahead and I'll be selfish and use these big brains. So Samantha, maybe I'll continue with you. I heard earlier someone say, well, I didn't learn this in medical school. Our faculties of medicine, our residency programs, are they doing a better job of talking about climate change and the impacts and getting to doctors to talk about this?
Yeah, definitely. Thanks to advocacy by medical students, really. Medical students saying, we need to know this. This is the medicine of the future. And also, we're very worried about climate change and its impacts on health. And so because of the advocacy of groups like the CFMS, the Canadian Federation of Medical Students, we do now have climate change content in the curriculum of every medical school across the country. And also, it's coming to curriculum for residents as well. So it is integrated, but the problem is, like I said before, education is insufficient, and what we need is really systems change and buy-in from hospital executives and CEOs, and unfortunately at that level, often they don't know what they don't know, and so that's where we also have to teach advocacy. We also have to teach change management skills so that, sure, the medical students are graduating with a knowledge of the climate impacts on health, and then we need to teach them how to fix the system.
Yeah, so it's one thing to learn it, and then you walk to work and you walk by the big smokestack at the hospital spewing out all this crap.
Yeah, so they have to figure out how to communicate with that hospital CEO and tell them, this is actually harming our community and our patients, and this is what we need to do to fix it.
Now, Prativa, I've talked a lot this morning with different panelists about eco-anxiety and such. How do you deal with that in public health? Public health, you're supposed to be the positive people.
Are we?
I think so. I guess that's the answer. I guess you're not.
No, I think this is something that I'm going to, preemptively answer a question that you're probably going to ask later, which is when I started my PhD in 2019 and I wanted to do work on climate and health, this was at Hopkins, I was told there's nobody working in that space. And now, here we are, a couple of years later, and there's so much work that's being done in this space. So I think a big chunk of young people's hope in navigating eco-anxiety is this recognition that there's action, there are communities that are working in this space, rather than us doing this in silos. Just the sheer fact that I'm here and that I'm a health systems researcher and epidemiologist, but I'm surrounded by so many people that are working in the climate space, is this recognition that there's a lot more of us doing work in parallel that impacts both of our fields than we were even a couple of years ago, where everything was siloed. So I think to respond to your question, I also teach an undergrad class at McGill on foundations of global health, and there's a lot of eco-anxiety that's present, and yet young people are galvanizing themselves and saying, well, nothing is being done, so it's kind of up to us, I guess, to do something about it and to learn skill sets like communications, which is so critical, and we've heard that over and over again, but it's not something that was necessarily prioritized. When I was doing my PhD, again, comms was not something that was prioritized, and so navigating how to communicate uncertainty during a pandemic, during a health emergency, these are critical skills that I think we should be training our young people in, and these young people are learning how to do that on their own through TikTok, through social media. So I guess dealing with eco-anxiety by acting and finding community.
And I think we've heard that over and over again. Ask questions, be out there, be advocates. The world has changed a lot. And I think you reminded me too, that I haven't mentioned this enough, we do have the panelists are a lot of groundbreaking people. This is fairly new stuff, and we have a lot of groundbreakers here today, and to give them credit. So I see an audience question, so I'll be quiet.
Oh. My mic is on. There we go. Hi. Thank you so much for sharing your perspectives. I had to write down my question because I was trying to organize my thoughts. I'm a medical student who's in a physician scientist training program at Western University, currently doing my master's in epidemiology, and I'm interested in primary care. So, you're preaching to my choir. I'm really, really receiving what you both are saying about capacity planning. This is something I stew on, and so I think both of your perspectives, and maybe I'm biased, would really contribute to helping me think through this. I had to write this down. So my question for both of you, and apologies if it's loaded, is how do we reconcile with the critical role of primary care physicians in safeguarding, especially vulnerable communities, to climate change related events, with the lack of family physician availability in our region and the frank limitations of the physician role imposed by climate change? Three very big intersecting issues, and I don't know where I land.
Samantha, that's an easy question. You can do that one.
Well, absolutely. Investment in primary care is important just, broadly in our society. It also reduces the pollution caused by the health sector. If more people had access to a family doctor, that would be fewer emergency department visits, fewer hospitalizations, so fewer tertiary care needs, and that means less climate pollution from the health sector. So it is in and of itself a climate solution. And then it's also family doctors are leaders in their community and can therefore leverage that trust that we've talked about to talk about climate health impacts. So I agree that investment in primary care is absolutely needed as a climate response, as a climate solution.
Okay. Yes.
I'm not sure if this, yep, sounds like it's on. A question from a resident in Manitoba who says they're noticing a huge lack of climate health teaching in their curriculum. Any recommendations for resources or how to advocate for more climate-related material in their training?
Who wants to shame the University of Manitoba?
The CFMS, the Canadian Federation of Medical Students, has done a great job. They have a whole task force devoted to promoting planetary health in undergraduate medical education, and so connecting with CFMS, I think, would be a first step. And it is coming to CanMeds, which is used. CanMeds is a framework that's used by residency education programs across the country and undergraduate education across the country to frame how they teach medicine. And there will be planetary health content coming to the new CanMeds in 2026. So hopefully that will support these students at the University of Manitoba in getting more content into their curriculum.
Yeah, go.
And just to add to that, there are a lot of flagship reports that are more and more including planetary health as part of their definition. So in global health, for example, which is the field that I operate in, there's a new report convened by the Royal Society of Canada that was released earlier this year. And for the first time, we included planetary health into the definition of what it means to be practicing global health. And so pointing to these reports might further push and provide an opportunity to advocate as well.
And I'll just add, Owen, who's on our next panel, does a lot of education of medical students, and I looked over, I think he was already booking a ticket to Winnipeg, so stay tuned. Yes?
Hi, thank you. I'm Dharmishta Kaul. I'm the Senior Public Health Specialist with Canadian Red Cross. Our Canadian Red Cross has been supporting the climate-induced displacements and extreme weather displacement. The recent one has been the wildfires, Manitoba, Saskatchewan, and Atlantic. One of the first-hand experience which we had as a part of health and emergency team there was a reluctancy in seeking the formal health care. And we observed that it's not segregated by age or elderly or pregnant. Those are the hidden vulnerabilities which we found a lot among the displaced population. As you mentioned, Dr. Green, as you mentioned about the trust with your patients and all that, that factor might not be there with the internally displaced population. What strategies you think can be helpful and can help to identify those hidden vulnerabilities? Thank you.
I think more generally talk about, culture is important, right? We have to change culture to changes.
Yes, you've made
They're fighting about who should answer.
Yeah. I mean, it's a great question, how to identify those who are most vulnerable. I mean, I think we do know a lot of the time that it's people who are already marginalized, people living in poverty, people who are racialized, Indigenous communities. Those are who are most at risk, and I think that's why we need kind of policy level protections and solutions for people, because it's really it's that universal protection that will support people in a wildfire evacuation, an extreme heat event.
Yeah, and just to add to that as well, I think it further speaks to the need for infrastructure and processes that are already in place well before an emergency hits. So what we mentioned earlier, the idea of a civilian reserve, if we had local operating civilian reserves, they would be able to kind of recognize those vulnerabilities at real time in a way that other operations might not necessarily be able to. So I think we just need to be more, this was talked about quite a bit today, just the idea of being more local in order to identify those vulnerabilities quickly so that we're not neglecting important communities.
Yeah, actually I can add, there's a community organization called CREW, Climate Resilience to Extreme Weather, that is operating in St. Jamestown here in Toronto. And what they're doing is developing a list of who is vulnerable, like on my floor, in my building. Well ahead of an extreme weather event, and they're building those community infrastructures already. So that's what we need, in all of our communities.
Great. And a great note to end on about preparation, being ready. Thank you to Dr. Prativa Baral, Dr. Samantha Green for being there. Sorry to the people who we didn't get your questions, but corner people during our networking after. Don't be shy, that's part of what this is about. So thank you again for being there. Thank you. Thanks. I'm going to kick you out and invite the next people. So we're going to bring up another chair, and while they're doing that, let me introduce our next panelists. We're going to focus on how healthcare can operate more sustainably on our next panel. Many physicians and hospitals, for example, are striving to be part of the solution by changing the way they run things. Various statistics peg global emissions from healthcare in the range of 5 to 8%, so there's certainly a lot of opportunity for change. And we have a group here to talk about how we can do that. So let me introduce, I'll start with Dr. Courtney Howard in the middle, an emergency physician in Yellowknife in Canada's subarctic. Among her other roles, she's chair of the Global Climate and Health Alliance, and of course a member of CAPE, longtime member. Welcome, Courtney. We have Dr. Owen Dan Lau. I don't have you guys in order this time. I'm all mixed up. An internal medicine resident physician at McGill University in Montreal. I mentioned you do a lot of education. I think you're on your way to Winnipeg after that question.
Absolutely.
Yeah, so good. And finally, on the end, William Gagnon, a sustainable health systems expert. He's also based in Yellowknife. So welcome to the three of you. Now, we're getting late in the day, so there's more pressure on you to give more take-home messages. So now, William, I want to start with you because I mentioned this figure, 5 to 8% of all emissions come from healthcare. Can you help us understand where it's coming from? Is it just garbage? Is it that stuff coming out the smokestack at every hospital? What's causing these emissions?
So I speak to a lot of physicians, and the first gesture they do is often this: I'm tired of opening packages. They'll do this gesture, and single-use plastics is, I think, an entry door for a lot of physicians. In reality, 70% of emissions are coming from some supplies and drugs and anything that's produced outside of the hospital. And we have about 10 to 20% of the emissions that are related to buildings. So that's natural gas that's being burned, or often also the on-site emissions related to desflurane, so anesthetic gases like nitrous oxide as well. So I would say most of the emissions are actually happening from outside the hospital.
But is there too much plastic in hospitals? Can we do better? Can we do less single use? Is there potential there?
For sure. We definitely need to do more reusables. And in fact, most of the studies that I read on reusables say that reusables are always better for climate and often in terms of money as well. So I think it's a really good practice to change away from single use. I feel like the single-use plastics are harder to switch away from. The easy wins, the quick wins are decarbonizing anesthesia. And so I think we're getting there slowly. There's a lot of work happening in Toronto specifically on this.
And let me speak for the non-physicians in the audience and say, what the heck is desflurane? How does that pollute?
So I'm an engineer, and I'm really out of place to talk about this. And I'm glad that most of the anesthetists, I think all the anesthetists are gone, so we can have a real conversation about it. So desflurane is a anesthetic gas. So you breathe it in, and then that puts you to sleep, and so they can do surgery on you. Desflurane has a super, super high global warming potential, so it's 2,500 times the impact of carbon dioxide, but there are replacements to desflurane, like sevoflurane, which is, I think, 250. So that's already a good transition away. And others are transitioning to total intravenous anesthesia, which has way less greenhouse gas emissions, but other impacts. And so I think we're starting with the big hitters. So desflurane has been phased out in Northwest Territories and Nunavut and Newfoundland and Labrador. We're working towards phasing it out in other provinces and territories. BC is doing really well, with 4 out of 7 health authorities having phased it out. Quebec is doing also really well. Ontario is doing extremely well under Dr. Anita Rao's leadership. Nova Scotia, I see Dr. Sean Christie here, who have bugged many times about bugging his colleagues about phasing out desflurane, and I know that you guys are so close, so don't give up. And the goal is to phase it out nationally, because those success stories, I think, bring resources, bring media attention, and bring people interested in helping us do the change.
Yeah, it changes the conversation a bit. We don't necessarily think about it. So Owen, you were honored recently by the CMA as a young leader for your activism, particularly on climate change. Congratulations. Could you tell us a little bit about the work you do? I said you do a lot of work with teaching medical students and projects like Earth. Can you tell us a little bit about that and why it's important?
Yeah, for sure. Throughout my medical education, I've been quite privileged to work with many leaders in this health sector space and medical education space, trying to make sure that future healthcare professionals are being taught about how to practice in a climate crisis. So that's been a big priority of mine. And through our work evaluating curriculum, we realized that healthcare trainees and medical students are really looking for more opportunities to engage in healthcare sustainability and reducing the carbon footprint of the practice that we're going to future inherit. And that has been a priority for us. And with that knowledge in hand, we founded Project Green Healthcare, Projet Vert Santé, which was the first of its kind national community of practice of medical students that were leading green change initiatives across the hospitals in Canada. And over the years of 2020 to 2023, we had about 20 teams come through our program of medical trainees that have done work related to anesthetic gas, work related to waste disposal and distribution, and also looking at ways to choose wisely and do healthcare research stewardship to practice on a smaller carbon footprint as well. And with that program, we've been very lucky to actually build a whole generation of healthcare providers that are now in residency, and some of them in practice, that have learned from our program to become lifelong healthcare sustainability champions. And with Earth, which is environmental action for residents and trainees for health, it's a new program that we've just received funding for that's essentially building off the momentum from Project Green Healthcare, but also including residents, as I'm also a resident myself, so that we have the undergraduate and postgraduate medical education trainees involved on this important topic.
And what do you teach them?
Yeah, so in this program, most importantly is to teach them with experiential learning opportunities by giving them access to funding, mentorship from the Canadian Association of Physicians for the Environment and the Canadian Coalition for Green Healthcare. Our trainees have an opportunity to kind of grapple with healthcare sustainability, quality improvement, which is to kind of look at a problem in healthcare, try to see what the local needs are in terms of what has been done before, tried before, implementing programs, maybe big, maybe small, to try to reduce the carbon footprint and evaluating their success. And with that, they're able to have a mindset that is like based on quality improvement that allows them to grapple bigger issues as they move forward in their training.
But when you're in med school, when you're in residency, you don't think a lot about reducing waste and anesthesia gases and things like that. Are you trying to change that?
Certainly. It's definitely something that we're not really taught about, but this has started to change, as we talked about earlier in our last panel discussion, through the work of many different healthcare leaders and medical trainees that have pushed for a curriculum, particularly in the undergraduate medical education space. As a resident, I'm certainly still disappointed that postgraduate medical education has been lagging behind. I do know there's a lot of innovation that's going to come with a refresh of CanMeds 2026, which I'm really excited about seeing and pushing towards more curriculum. And I think with that knowledge in hand, that's the most fundamental baseline to start somebody on a journey to become a sustainable champion. Because without that knowledge, it's difficult to understand the issue, believe in it, and be motivated to change it.
But it's still first and foremost, don't kill people and help them get better, and then the packaging stuff?
Certainly, like the medical expert competency remains at the center of our training. But I think one thing that I wanted to say is that being a healthcare sustainability advocate really made me recognize that planetary healthcare, healthcare on a smaller carbon footprint, is good healthcare. And I think that's really important to emphasize, and that by choosing to practice on a smaller carbon footprint with high value care, we're actually doing good for patients and our population.
And that's what I was trying to get you to say with my snarky question.
Sounds good.
Great. Courtney, I wanted you to build on something that Owen said in passing about, that this is about quality improvement, right? It's not just fluff, as we say in French, but this is about making the system better and making people healthier.
Well, you probably know the story now that in 2023 we had to evacuate our entire 100-bed subarctic hospital on 2 days' notice. So we have to decarbonize. We also have to adapt. And that's having material and extremely expensive impacts on healthcare already. So my neighbor is the territorial medical director. Because this isn't mainstreamed in medical education or practice, we didn't have a hazard assessment that was ready for the wildfires of our century. And so you can imagine what it does to a medical community when you have 2 days to figure out how to have a military evacuation plane take your patients all the way down to Vancouver. So think of how much that cost. People lived as evacuees for 3 weeks. Now, I'm now the president of the Northwest Territories Medical Association, and I can tell you it is not easier to keep your emergency department open in the wake of a trauma like that to your community. So basically, mainstreaming climate resilient, low carbon healthcare is the only way we're going to keep healthcare. And I think that what's really important for us to realize is that when we look at where we're heading on a global scale to over 3 degrees Celsius of warming, I'm the chair of the Global Climate and Health Alliance, and at the last climate change negotiation, The Economist magazine convened a panel of healthcare adaptation experts and asked us, okay, so can we, if we adapt as well as we can we adapt enough that we can maintain healthcare that people would find acceptable to where we're going right now? And we just went around the table, and it's hard to get this from a journal article because people try to sort of couch words and say things in a fancy way. It was no, 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 no. And so when people really think through what it's going to take to keep a hospital open in the midst of wildfires and heat, I find that physicians very quickly get the bottom line and they're like, oh, and all of a sudden they're extremely motivated to also decrease greenhouse gas emissions through the emissions that we control.
Because it's going to happen again.
Well, unfortunately, earlier this week I had a text from the on-call physician saying that the nursery smelled like smoke and there was a newborn in there, and this is a new hospital. This is a $1.2 billion new hospital that we as taxpayers have paid for that's supposed to last for another couple of decades. So until we mainstream this, we're just going to be making inefficient investments that are going to result in poorer care. We don't have enough money in healthcare to be making inefficient investments in the state of our finances with an aging population. We need to be as efficient as we can to be as effective as we can to provide excellent care.
But climate disasters aren't new. We saw during Hurricane Katrina, they had to evacuate hospitals. They failed to evacuate nursing homes, resulting in mass deaths. Why weren't we ready?
Great question. In Canada, so fossil fuel companies have had, just as they did with tobacco, and in some cases using the same public relations companies, a very specific and purposeful campaign of misinformation. And because we've been so slow to get this into our curricula, we haven't really been there to counter what's in the public space with proper evidence-based facts. And so many people are working with a mental model that they're unconscious. They don't know that really it's the fossil fuel companies that have fed them their mental model. And so really one of our jobs is to upskill our entire profession as quickly as we can so that when someone says something like, natural gas is a climate transition fuel, we can say, no, actually, methane actually has a massive climate warming potential, particularly over the next 20 years. And what we really need to do is emergently decrease before we hit tipping points in the Earth system. Around 1.5 degrees Celsius, we start to get to the point where the coral reefs start to not work very well. The permafrost under my house in the Arctic starts to melt, which releases more methane, which can start to create a positive feedback cycle in the Earth system. So when I'm in the Emerge, when a nurse comes and says, hey, Courtney, this patient's getting unstable, that's the next patient I go see because I know that if I'm not fast, they can start to spiral and start to crash. That's one thing they get right on the TV shows. We need to act before the Earth starts to crash. We do not want to get into these positive feedback loops. And so we heard from Kim earlier how oil and gas emissions, they've kind of been given a free ride, and that's partly because they're controlling the narrative. We need to make really clear to people that a healthy future requires a really rapid low-carbon transition. And because the health sector globally controls 10% of global world product, and we now have over 80 countries committed to this, through the combination of procurement and purchasing and the narratives around a healthy future, I genuinely believe, and the tipping point scientists globally believe, that the health sector can be absolutely key to leading a healthy low-carbon transition.
Good. Let's hope the pit tackles climate change in season 2. They did a great job with measles, so we'll see. William, you mentioned you're an engineer. Do we need to have a better relationship between the engineering and the medicine to do the prevention stuff? Like to build hospitals differently, for example, to have different gases, like do it all up front rather than, it's kind of being done hodgepodge right now.
How many engineers in the room?
Woo!
Great. There's one who's on my team, and the other one's, great. Yeah, so I think, so doctors don't have time. That's pretty clear, but they have authority and they have leadership. And so what we need to do is to equip them with a bigger team so that we can implement those decarbonization interventions. And I think, so the people who are going to come up with the solutions is most often the clinician who is closest to where the emissions are happening. So in anesthesia, it's going to be an anesthetist who decides on which gas to use. In family medicine, it could be on prescription. And then I think we need support teams that are going to implement those decarbonization solutions at scale. As I said earlier today, we don't need 13 anesthetists in 13 provinces and territories figuring out for themselves and doing the discovery process of where are the emissions coming from in my practice and how do I decarbonize. I think we need to connect those people together. And this is what I hope to be doing.
But we don't do a lot of that in Canada. We do a lot of reinventing the wheel.
Nation of pilot projects.
No. Or reinventing the anesthesia gas production or something. Okay. Owen, the health system has a lot of challenges. It has staffing shortages, overcrowded ERs, the list is very long. How do we make the case that this matters? Like changing anesthesia gases, cutting packaging, teaching students. How do we make this a priority when there's so much urgent stuff going on?
Yeah, I think that's a great question, and I think it's really important not to like emphasize planetary health over all the other competing interests. But I think one thing that I've really motivated myself to understand why this is such a crucial, pressing issue is that planetary health in a complex system like ours intersects with so many of those other issues that you were talking about. And I think what's especially scary about planetary health threats is that not only are they making our patients sicker, they are also making it more difficult for us to do our jobs well, like what Dr. Howard just talked about how her hospital had to close down due to environmental disasters. And we're starting to see that in hospitals across the country where wildfires have made it dangerous to practice and or keep hospitals open. And in those times of wildfires, our patients with respiratory diseases are going to be exacerbating and require care more than before, but they can't access that care and they have to be diverted to other places, which may already be full of patients in need of health services. That's extra scary. In addition, I think, and what makes the impetus strong in healthcare is that, you know, all of us in healthcare have at least heard about the Hippocratic Oath, and I think we try to abide by that as much as possible, which is to do no harm. And unfortunately, what we've talked about and what we've discussed so much during these panels is that healthcare is not fulfilling our mandate, that by practicing healthcare, we may be treating a patient in front of us, but we are causing inadvertent harm to the populations that surround our health system and to the global systems that we are global citizens of. And I think we need to reconcile that. And as a trainee in healthcare, I have a lot of moral injury as I practice and learn, and I try to make influence change. By addressing those things, by reducing the carbon footprint of our care, we address that moral injury of our healthcare system, which is being affected by an epidemic of burnout as well. So I think for all those reasons, it kind of becomes very salient while also addressing those competing issues that it intersects with.
And you mentioned you are a trainee. I'm trying to phrase this politely, but medicine's very hierarchical. So do people take well when you're telling the upper people above you to change? I can't imagine that goes well.
It's a good question. I think it really depends on the person, of course. But I would say as a trainee, what I've been very thankful for is that most of the superiors, the attendings that I've worked with, have been flexible with their ideas, and at least have been interested to hear my perspective and what evidence that I've used to have my worldviews built. And I think that has been super helpful. And I think by having the discussion in a way that doesn't antagonize them, because I think, of course, that's the scary thing about climate change and all of these things, because we have to reconcile with our own contribution to it at every kind of step of the way. And sometimes that kind of awakening, of course, causes that moral injury, and that invokes eco-anxiety to the person you're speaking with. And that and even include that kind of super scary staff that we talk about as trainees. They can get scared too, I think. And I think by talking about the evidence and about focusing on the avenues of opportunity and how we can do better as a community, and showing them that there have been, you know, small-scale projects or evidence that suggests that we can make this change, which may be an easy change even, and make a huge difference in the carbon footprint of our care and our quality of our care. I've been very fortunate that a lot of my supervisors have been interested. So for example, in internal medicine, I take care of hospitalized patients. And one of the most common things we do in hospitalized patients is we give everyone a shot in the leg for DFD prophylaxis. And DFD prophylaxis, of course, is very important. We've got to prevent clots in patients that are not moving very much and have infections or inflammation that cause them to form blood clots. But not all patients require that just because they're admitted to the hospital. Some patients have lower risk, or some patients have higher risk. And without thinking about it, sometimes we just slap it on, and it has a significant carbon footprint associated with the syringes, and also heparins are made from porcine mucosa. And so there's a lot of related animal carbon footprint that's associated with heparins and our use of blood thinners. So by thinking more critically, and I use risk scores for patients when they come into the hospital to basically deprescribe DFD prophylaxis for certain patients that are low risk, my staff have been interested in learning more about that and letting me as a senior resident make those calls about my patients to provide better care for them.
Yeah, I've never made that link, deprescribing and climate health, but it's a good one. I'll add it to my list. Now, Courtney, you and many people in this audience, you do a lot of advocacy. You travel around the world, you speak to conferences like this, but you're doing this all essentially off the side of your desk. It's not your job. Do we need to make this more systemic?
She loves being unpaid.
Yes. Oh, I guess he's answered for you, thank you.
People in this room, some of them have been on the receiving end of an email from Will being like, Courtney requires a speaking fee. And actually, I have a very, very patient pediatrician husband who has underwritten a lot of planetary health work in Canada because he cares about the next generation. It's really sort of a joint contribution. But if we want to scale properly, yeah, we need to start paying people for their work. And part of that is we need to start paying people for their work within the system. Where this is really working and cohesive around the world, at the NHS in the UK and Singapore, at one point the NHS team I know had 150 people working on it. And so what that looks like is a central team of physicians and accountants and lawyers and policy people setting policy nationally. And then regionally, similar things, and then a green team at every hospital where people actually have time to go and make the rounds, collect the data, et cetera. And what they've actually managed to do, they actually have, every single hospital now has a net zero strategy, and it's written into law. So they're accountable for it in the Health and Social Care Act, which sits under their Climate Change Act. So you can see how a rational approach works. So of course, they're a single employer. We're a federated healthcare system, and so we spent a lot of time over the last couple of years trying to figure out, okay, how can we jerry-rig this in Canada? Because the Association of Faculties of Medicine of Canada has shown just a tremendous amount of leadership in bringing forward a declaration on planetary health on behalf of their learners. And Dr. Connie LeBlanc, their lead, is in the audience today. She said they feel like a proud parent now, and I think it's just so appropriate the leadership came from there. So we now have a roadmap, and we were talking about it this morning, and really the key thing we heard over and over is the need for collaboration. So to make these links in our federated health system, so we're not reinventing the wheel all the time. And so we've come to the conclusion probably a National Resource Center for Planetary Health that deals with practice, research, and policy, as well as an advocacy engine to move it forward, is the way to go. And yes, people need to be paid because, as you get older, it's tougher to work the night shifts and then do this stuff the next day, Andre. So, we want to make sure that people obtain value for work. It's life-saving work, and we need to value it.
And the starting point, if we're not going to get to the NHS level anytime soon, but the starting point is just sharing the knowledge so people don't have to start from scratch in every province and region.
Yeah, and that improves mental health because there are networks that have been trying really hard, Cascades and the Canadian Coalition for Green Healthcare, but it's patchy across the country. So particularly in rural and remote areas where sometimes the impacts are worst, people haven't found their people. And so they'll contact me and they'll say, Dr. Howard, I'm trying so hard to phase out desflurane, but I, don't have the stats and my department head hasn't been briefed yet, and they're lonely. And so when we take into account the fact that 37% of Canadian youth under 25 tell us that worry about climate change is affecting their daily function. So we're asking people who are deeply, deeply existentially afraid to now be on their own, unsupported, and try to save the world. It's actually unkind. And there's work done that shows that when we take action on climate change, particularly in a group, it reduces eco-anxiety, which makes a lot of sense because you're reducing a real threat, right? I always picture standing in the middle of the road, holding my daughters, one on each hand, with a truck barreling down on us. That makes you anxious too. But you can't yoga breathe your way out of a real threat. You can yoga breathe, center yourself, and then move out of the way, decrease the actual threat, and that's what we need to do now, and supporting people to do the work is part of that.
Okay. Now I want to give the audience a chance to ask you questions as well, but I'm going to ask one more of William while the mics come to you. I see one in a hand up in front here already. William, this will be an easy question. The 5 to 8% of emissions is healthcare. Can we get to net zero? Is that doable?
We have to get to net zero. We're not going to eliminate all emissions. There will be some remaining emissions that we might not be able to eliminate fully. We might need to keep diesel generators running for emergency situations. But we're also going to have to ramp up our negative emissions. So that means planting trees. If you build a hospital out of wood, what you're doing is you're actually storing carbon in the form of wood in building, and so that's not new. There are tons of ways. So some are better intended than others. So, and hence oil recovery, for example, is a way to just push CO2 down in the ground, and then you say, oh, we stored carbon, but we also used the pressure to extract more fuel, which is not the point here. So I think we need to accelerate our decarbonization, but we also need to accelerate the way that we're going to generate negative emissions, so that we can reach net zero and stabilize the warming, because we don't want any more warming.
And we can do little things like plant trees around hospitals, et cetera. They should be leaders by example.
Yes, 100%.
Okay. So audience questions? Yep.
Hi, my name is Hashim. I'm with the City of Mississauga Climate Change Policy team. My question is for Dr. Courtney. I think this is something also that was alluded to by, I think, Kim before when she was speaking. Just the mindset of somebody who experiences a climate disaster. I know you're talking about evacuees and people leaving, and how are they able to associate that action or what was happening with actually the cause of it, which is potentially oil and gas? And is that something you're seeing, or is it a communication problem? Like, because I think even the thought of somebody who had to evacuate themselves or their family going on just months later to now advocate or even support oil and gas just sounds like unfathomable to me. So is that something you're seeing, or is that something, or is this a messaging problem that needs to be like tackled? So I just wanted to hear your thoughts on that.
I think you're right that there's a communication problem. There also for a long time was an attribution problem. So we knew that climate disasters were increasing, but we hadn't, from a data perspective, gone through the math of figuring out how much of that was due to climate change. And that's a place where the science is really improving. So just last month, I was part of a press release for a heat-related study out of the Grantham Institute, and they were talking about attribution of heat-related deaths to climate change, and they wanted a physician there to just say, well, what does a heat-related death look like? So we're getting better at that, but you're right. At that point, we then also need to take the extra step, and I think Kim did a good job of that earlier of showing, well, look, a lot of our emissions are still coming from oil and gas. And I think what's really important for us to know is we're subsidizing oil and gas in Canada. And so when you think about all of the health impact and health system impact now and into the future, it's not a good investment. And we've been talking about externalities. Something's only an externality if it didn't get included in the equation, and we're the people who create the equations. So that's something I think we need to change. And so when I did a master's in public policy recently, and I did a lot of work looking at next steps towards a well-being economy for Canada. And one of the first things that we ought to do is start to do comprehensive wealth accounting. They're already doing it in New Zealand, so they keep track of their ecological capital, they keep track of their human capital, their social relationships, as well as their built and financial capital. So now if you've got multiple ledgers, you're keeping track of extractions from the ecological capital. And so that way I think we can stop, it's not an externality, you just didn't do the math right. And frankly, at this point, I'm not interested in the results of equations that don't take into account everything we need for health and health systems to be functional.
William?
After the Yellowknife evacuation in August 2023, we were actually scheduled to have an election, I believe, in September 2023, but it was pushed back because 27,000 people didn't have a house. And I was asked to comment on Radio Canada on the election. And so I read all the profiles of all the candidates who were running to be MLAs, members of the Legislative Assembly. And what struck me is that 17, I believe, out of 19 or something like that, had mentioned climate adaptation or fire smarting. So we had just gone through, obviously, a really traumatic episode of wildfire, and everybody was like, oh, we need to do fire smarting. And I think it's going to be much easier for politicians to say, hey, we need to do climate adaptation, because people will be like, yes, we want the hospital to continue running, so we need to make sure that all the storage stuff is above flood lines. We need to make sure we have air filters so that if there's a wildfire, we can continue operating. I think the really hard part is going to be to convince people that we need to do mitigation, because it's harder to see. It's further down the line.
I think we have a question here.
Oui, j'ai une question sur l'approvisionnement durable. L'éducation, c'est important, mais aussi l'adaptation, c'est pas possible parce qu'il n'est pas de nouvelle normale. Le normal se change tout le temps. So, c'est important de faire la mitigation aussi. So, 70% des émissions à effet de serre sont de le secteur de la santé, c'est de le système d'approvisionnement. Il y a une théorie d'approvisionnement durable, mais comment est-ce qu'on va convaincre l'industrie pharmaceutique et aussi l'équipement médical de changer leur pratique de travail?
William, je vais vous laisser répondre.
Très bonne question. En fait, je pense qu'il va falloir qu'on construise des partenariats globaux avec d'autres pays. Donc, si le Canada dit, nous, on va juste seulement acheter des seringues écologiques, ben, on n'ira pas loin parce que les producteurs vont dire, ah ben whatever, genre on va en vendre aux États-Unis, on va en vendre au UK. Alors, je pense qu'il faut créer des consortiums de procurement, d'approvisionnement globaux pour pas laisser comme la compétition fuir vers d'autres marchés. Does that make sense?
Yeah, and just to say, they're waiting for Canada to arrive.
Yeah.
So we spoke with Chris Gormley, who's the head of Greener NHS, before this gathering to just get an update. And so the NHS already has green procurement standards, and they are a massive employer. So basically, once they brought those in, the pharmaceutical companies started paying attention, and they're now working with a group mostly of other high-income countries. And they're like, Canada, get your act together. Because essentially, we need a sectoral approach to convince the pharmaceutical companies that we're serious, that we need them to decarbonize their supply chain so we can decarbonize. And I don't know about you, but there's something about international competition that makes me very competitive. I've mostly left my type A competitive self back in my 20s, but on a national level, I can really get kind of riled up still. And so I do not like it that we are not at the table delivering our part, because this is a really important part. And I think that a gathering like this is actually the start of us showing up and being able to play our part in that whole international supply chain decarbonization discussion.
Yeah.
Et on en français ou en anglais, à ton plaisir.
Oh, merci. I think also one thing I want to outline is that sometimes as like an individual healthcare provider, we can feel overwhelmed that like 70% of our healthcare system's emissions are from supply chain. And it's like difficult as a frontline provider to be like, how can I take action? One thing I think that's quite helpful for myself is actually thinking about ways that we can reduce our utilization of healthcare service, either by preventative healthcare or by doing healthcare resource stewardship. As we do know, about like 15 to 30% of healthcare across the world is perhaps low value or unnecessary. Cutting that out would take a stab at 70% of our healthcare carbon footprint. At the same time, making people healthier, keeping them outside of the hospital, keeping them outside of the intensive care unit, which has a gradient of carbon emissions, and keeping them in the community will have a huge impact as well. So I think that's how, as an individual, I try to reconcile that 70% and how I can make a dent in it.
I don't see any other questions, but I can't see the whole room. We're good. William?
Can I add on procurement? I think manufacturers notice what's happening. So I spent 2024 in Singapore, and we had a big campaign to eliminate desflurane, and I was invited to this dinner paid for by Baxter. So Baxter is a company that produces desflurane. And the title of the dinner was, "Are we about to ban desflurane?" And they flew in this guy from Germany who was there to tell an audience of anesthetists who had zero climate knowledge why they didn't want them to stop using desflurane because they were going to lose market share. And so I get there, hello, Mr. Gagnon, would you like a parking voucher? Here's a 5-course meal in this bougie hotel. Very, very, very catered, very, lots of money, like we organize a full day event, we have $5,000 on Friday, and there I'm sure they had like way more than that because he flew this guy. And the more this guy was talking, he was spewing a lot of really complicated climate science to a bunch of anesthetists who don't understand climate science. And then I realized, he's just really dumping a lot of information to get everybody really lost in the audience. And then he said, see? That's why we don't need to ban desflurane. And I was texting Courtney at that moment, and I was like, this is not even worth the free rosemary chicken.
was so funny because he's an engineer. So I was trained by the Therapeutics Initiative at UBC, and we, way back when, you know, I haven't been to a drug company funded dinner in a really long time. And we know that all of the studies show that as a physician, if you go to a drug company dinner, you don't think that your prescription practices change, but stats show that they do. So we all think that we're the exception to the rule. And so this is all stuff that's been part of my training, but they don't do that to engineers. So this was Will's first introduction to drug company dinners. He was enraged. WhatsApp was like, "Can you blah, blah, blah." I'm like, it's okay to leave, Will. It's the right thing to do. But it sort of shows you how advanced the lobbying is. And that's one reason why advocacy instruction is so important, because if we don't train our medical students and our other health professionals how to go to a decision maker and make a succinct pitch that's action oriented, that is actionable by the person they're speaking with, we just get out lobbied, and that's what's happening right now. And what I love about the Canadian Federation of Medical Students Associations, Will and I presented to them yesterday, they're having a lobby day today. So they're spending today in their provincial governments in an organized fashion asking them to create sustainable healthcare secretariats. So a group within the health ministry that will own climate resilient, sustainable, low carbon healthcare, so that the issue's not continuously getting passed back and forth between the environment and the health ministry. So med students once again are leading, and the thing is, advocacy is a learnable skill set. You can get way better in a weekend course. And so we need to be bringing that to the table in order to help advance this work.
Now we're almost out of time. We've spent the day, we've talked a lot about problems, we've had some solutions, but I always want to end on a hopeful note. We're not living in very hopeful times, but I want each of you to send us home with a message of why you're hopeful this is going to change. William, do you want to start?
I think there's somebody thinking about decarbonizing healthcare in every specialty in the country. So we know, and anesthetists are kind of ahead because they were given kind of a free bingo square. But I think there's so many people thinking about different things, but we need to make sure we're not duplicating those efforts across provinces and territories. So my efforts will be focused on connecting those people together so we can kind of get ahead.
So you can multiply their impact.
Yeah.
Okay. Courtney, I think you're generally hopeful.
I am. And, 2009 I started working on this. So it's been 15 years moving from the periphery to really the main stage. And what is so exciting is this is the first National Day for Planetary Health. We're all gathered, and today we had, the Canadian Medical Association, Canadian Federation of Nurses Unions, many different disciplines in the room. And at the end of the day, we asked people, okay, do you think that we need a National Resource Center for Planetary Health? And are you willing to do things like go through bylaw discussions to make it? And the whole room put up their hands. So we have the first National Day for Planetary Health. We have a clear action pathway to a structure that can help us scale this, help province to province to province, us learn from the bright spots. And we know that when we build the structures, we've already got people who are so motivated, all they need is support. So I actually think we're at the moment of real liftoff, and that gives me so much hope. And you know what? It's going to feel good. It's going to be fun. And that's the part that I love.
Owen, the pressure's on you to send people home happy and hopeful.
All right. I'm a very hopeful person, and I think I have so much to be hopeful for as a trainee to, soon inherit the healthcare system. I think I came into medical school as somebody who was quite disenchanted to what we've been doing with the healthcare system so far, but over my last 7 years of training, I've seen how far we've come, how many people have been mobilized, the fact that we managed to fill a room like this to talk about this critical issue and to talk about solutions, not just the issue itself, has been crazy. I still remember when I started talking about climate change and lecturing medical students about this, I would spend like 40 minutes on the issue to try to convince them it's a problem, maybe 20 minutes for the actual issue in terms of how to solve it. Now my presentations are like 5 minutes of, this is an issue and everybody knows that that's a problem, and 55 minutes of action-oriented and solution-oriented content. So I think that's where we're at, and I think the solutions are coming, and the snowball is at the very top of the hill, and we're all part of it.
Great words to end on. Please thank Courtney Howard, Owen Liu, and William Gagnon. Thank you. Now, in a moment, we're going to invite Elder Wabagoon back to close the conference. And then you'll have a chance to network and continue conversations outside. But first, before ending. Yeah, don't worry, I've got my script. Yeah. But first of all, I want to recognize the Trottier Family Foundation for their support of the event, along with the CMA. And with that, I'd like to welcome Jean-Patrick Toussaint to the stage for some final words.
Merci, Monsieur Picard. Bonjour, tout le monde. Hi, everyone. It's very humbling coming in front of everyone after hearing such passionate speakers and dedicated speakers and practitioners. I just want to thank them again, and if you want to join me, I'd like to applaud them. If I can ask, with the technology, I've got a few slides, just a few things. Today was an incredible day of discussion, lots of energy in the room, and the word collaboration came up a lot, even this afternoon. So for those of you who are fortunate enough to be with us this morning, we had a lot of conversation about how can we make things happen. So we celebrated some wins, as we heard just recently with the last panel. William Gagnon gave some great example about the ban of desflurane across the country, what's happening. And we pushed forward the discussion for planetary health and sustainable health system. What really stood out throughout the day was the sense of urgency. We've heard it as well again this afternoon, and also the sense of possibility. And I was really inspired to hear from the youth as well, the new practitioners, that are coming up, that are stepping up and are taking on this responsibility. Now, why is the Trottier Family Foundation involved in this space? Who is the Trottier Family Foundation? If you don't know us, we're a private family foundation founded in 2000, and one of our biggest core portfolio is climate change. I'm one of 4 climate directors looking at how we can help leverage some of our funding to help accelerate change, and we want to be part of the solution. 2.5 years ago, almost 3 years ago, we took a pledge. We decided to commit $2 million a year to help decarbonize our healthcare system in Quebec, but we also saw the need and possibility about bringing folks together. Again, I want to come back to the collaboration part. I think we have a role to play, and that's why we're involved in this space. And so we do believe that philanthropy has a responsibility to act and an opportunity to catalyze systemic change. So I think we heard this afternoon, no one can do this alone. Together as funders, as practitioners, as educators, as policy leaders, we can transform not only how healthcare system respond to climate change, but how it leads as well. So if you're representing a foundation, and I know there's some other philanthropic foundation in the room, if you're an institution, a network, I invite you to see today as an invitation to really step up and get into this work. We do need you. We do need all hands on deck. On this next slide, what I'll leave you with is a call to action. We've heard about that in the last panel. Again, Courtney just mentioned it today, and as Dr. Burnell mentioned in her opening remarks for this afternoon, today corresponds to the first day of National Planetary Health, led by CAPE. Across the country, there's physicians and dozens of organizations that are committed to this action. CMA is one of them, so I invite you to scan that little QR code and see if you want to be part of the action. And if you're a physician, you can also look at this other QR code underneath the first one, which leads to the Planetary Health Pledge. So, as I said, everybody has a role to play. Leaders, practitioners, funders, allies. So I want to urge us to really come together and act together. Last but not least, I really want to extend a heartfelt thank you to our moderator, Monsieur André Picard. Thank you so much for your help. Thank you. I also want to thank everyone involved. For those of you, again, who were here this morning that made this happen, the team at the Globe and Mail for this today and this afternoon, this morning, the team at the CMA, the team working with Courtney Howard Power, so Courtney, Raisa, Will, and the team at Association of Faculties of Medicine of Canada. Again, I wanted to thank you, everyone, for your work. And of course, all the speakers this afternoon. It was really inspiring, as I said before, to hear you, to see that there's hope despite the challenges that we're faced with. And so this is very uplifting, and I think together you've shown what's possible, and that we can carry it forward. Now, before I leave, I want to to welcome back to the stage Elder Wabagoon to please send us off. So please, Elder Wabagoon, I invite you to the stage. Thank you.
So, ani, indenaway maganadok. Bonjour. Just before I go into the closing, I want to share a bit about the greeting I spoke. When I greet you with bonjour, in the way maganadok, ani, what I'm saying is all my relations. Indenaway maganadok means all my relations. I'm not just speaking to you, my fellow human beings, or to somebody who I have a DNA relationship to. I'm addressing the entire world because I have a relationship with all beings. I recognize the trees, the stars, the swimmers, the crawlers, the flyers, the two-legged and the four-legged as my relatives. And I recognize everything as a sacred part of creation, and it's that relationship that has made me a relative to them. You too can do this by shifting the way you look at things, by looking at everything as a sacred part of creation, a relative and not a resource. I know it might be difficult at first, but it starts, as with everything, with one small step. Listening to the speakers this afternoon, I remembered the words I shared recently with some people, just much like this audience. And it goes like this. Thank you. So I'll begin to close with the words of Kinipawit Masqua, also known as John Gonzalez, a Taino Pimikikamak journalist, filmmaker, and founder of the Standing Bear Network, in his reflective post titled, "The Fires Are Walking Again." And I thought it was important that I share these words with you as we spoke about the wildfires and how much we need wildfire management, better wildfire management. The fires are walking again. The old ones told us, when the balance shifts, the fire comes out, not out of anger, but out of need. The earth breathes, the trees speak, and when the winds carry the flame, it's a reminder that we are still all tied to the laws of creation, whether we remember them or not. In Matthias Colum, which is a reserve, 2,300 of our relatives sit waiting. There's no road beneath their feet now. The planes have nowhere to land. Only small birds, the helicopters come and go, carrying 6 souls at a time. It's like trying to empty a lake with a cup. In Tataqueyac, the power is gone. The roads are closed. The fire stands only 1,000 steps away. 200 have been moved to safety, but thousands more remain, watching, listening, waiting. The flames speak a language older than us, and they are saying, "I am near." The chiefs have called out, Chief Gordy Bear, Chief Doreen Spence, Grand Chief Kyra Wilson, Grand Chief Garrison Sati, and I stand behind their voices. They're not crying out for themselves. They're standing for the children, for the grandmothers, for those who cannot run. They're standing for the land itself. I say to those who hold the tools of power, This is not a time for papers and meetings. This is a time for action. This fire does not recognize jurisdiction. Smoke does not pause to ask who is responsible. It moves, and so must we. The Canadian Armed Forces must come. The helicopters must be more. The fuel, the generators, the lifelines, they must flow north like rivers after the thaw. Every delay is another breath of smoke in a child's lungs. Every unanswered call is a weight on an elder's heart. We ask not as beggars, but as sovereign nations, as caretakers of this land long before these lines on maps were ever drawn. The leaders have called for one table, a command where our own sit alongside those with resources. That is the way of respect. That is the way of partnership. That is the way of honor. You see, my relatives, when the fires come, it tests more than the trees. It tests our spirit. It asks, will you stand for one another? Will you carry one another? Will you be who you say you are? And so I say now, now is the time to remember our teachings. Now is the time to walk together, not behind, not in front, but side by side. For the earth cries, the people wait, and we who have been gifted with breath this day must answer. May the helpers rise swiftly, may the winds calm, and may the people be protected. Ikosi. Thank you, miigwech. So, as we close this circle in space, I want you to remember to balance the fire is water. And I want you to remember to say thank you to the water. I had several conversations with people on the break about water and how to have a relationship with your water. That cup that sits beside your bed, have a relationship and speak to your water. Love your water, hold it, respect it. That's a whole nother workshop. And I want you to hold that deep in your heart. And with every question you are asked, before you answer, ask yourself, am I being a good ancestor? When you make a decision, ask yourself, am I being a good ancestor? I now ask that you stand, and I'll ask that you turn and face the directions with me. We will honor, just a minute. We will honor and respect the four directions, the four seasons, the words gifted to us today, and say chi miigwech for bringing us together as one. We will clear the path for all to go home in a safe way with this vision song. This song was gifted to me by the Plant Nation, and it always calls the four directions for me, and it calls our ancestors to be with us. And I just want to give them the song that everybody go home in a safe way. So if we stand in the eastern direction, which is that way, and when I sing the verse, and then we're going to turn to our right, and then we're going to face the water, and then we'll turn right again, face the west, and then to the north. Way high, oh, way high, oh, way high, dee, oh. And it's to this eastern direction that I say, chi miigwech, to the ancestors that were here with us today. To all the words that we heard today, we say chi miigwech, chi miigwech, chi miigwech, waladen. To the southern direction, please, turn to your right. Way high, oh, way high, And it's to the southern direction and to the ancestors of the south. We say Chi-miigwech for coming and gathering with us today, giving us the path to strength, to knowledge, and the ears to listen, to take in all of this. We say Chi-miigwech, Chi-miigwech, Chi-miigwech Wolata. To the western direction. Way-hi-oh, way-hi-oh, way-hi-di-hi-di, oh. And it's to this direction, the western direction, where our ancestors rest. We send you home, and we say thank you. We say Chi-miigwech for being with us today, for gathering and being with us and showing us this path of gathering together, coming together as one. We say Chi-miigwech, Chi-miigwech, Chi-miigwech Wolata. And lastly, to the northern direction. Way-hi-oh, way-hi-oh, way-hi-di-hi-di, oh. And it's to this direction that I come to you as your great-granddaughter. And I say to Alex and Annie Sapé, Chi-miigwech for guiding me today, for sending me here, guiding me on this path, to share these words, these songs. I say Chi-miigwech, Chi-miigwech, Chi-miigwech Wolata. Chi-miigwech. Please have a seat. In closing, I say Chi-miigwech as I honor those who came before me. Chi-miigwech for the opportunity to be here with you. Chi-miigwech as I close this space. Apachigo, Chi-miigwech Bisandawayeg. Thank you for listening, and may our paths cross again. Bamapi, Bamapi.